Welcome to our December meeting. We're just waiting for a couple more board members to join us and we'll get started. Welcome everyone to December meeting at the Oregon Health Policy Board. I'm David Banksburg, Chair of the Board and Dean of the OHSU School of Public Health. It's great to have you join us today. As with other meetings, we're doing this by Zoom, and the chat feature allows you to contact the host of the meeting, but not the other people attending the meeting. If you would like to contact the host or reach out, please send us an email to healthpolicyboard1word.info@dhsoha.state.or.us. That's healthpolicyboard.info@dhsoha.state.or.us. And all the materials for today's meeting are up on the website, the Oregon Health Authority website. Feel free to reach out there or to the host today. We'll start off with a roll call. Steph, are you with us today?
Hey, David, I'm going to pitch hit for Steph today, so I'll call roll. We'll go in alphabetical order. Oscar Arana.
Here.
David Bangsberg.
Here.
Ebony Clark. All right. I see Ebony is just logging in. I'll come back to her in a moment. Jessica Gomez.
Here.
Thank you. Kristen Isaacson.
Here.
Brenda Johnson.
Here.
Thank you. Bill Kramer.
Here.
John Santa.
Here in audio only.
Great, thanks. And then I just want to confirm, Ebony, you were just logging in when I was calling your name. Can you confirm if you are here?
I'm here.
Great, thank you. All right, we have all members present.
Super. All right, welcome everyone. Well, it's our final meeting of 2021. We look forward to 2022 and would like to thank everyone at OHA for doing their leadership and great work managing the health of our state for the last year. We look forward to moving forward, clearly still during very uncertain times, but we really appreciate Director Allen and everyone at OHA leading the Oregon Health Authority. We also are looking forward in 2022 to having a retreat. Vice Chair Arana and I and OHA leadership spent a fair amount of time talking about retreats format. We had some discussions about an in-person retreat. We certainly do look forward to having an in-person retreat at some time, but due to the uncertainty of COVID, necessary COVID safety guidelines and mask wearing and some of the challenges hearing people who are speaking through a mask and possibly creating both an in-person and a Zoom environment, which could marginalize people on Zoom. We decided we were going to do our February retreat online in a Zoom setting, just like this, to provide some consistency and make access to that meeting more widely available. Over the next couple of weeks, you'll hear the members will hear some details about the retreat goals. We're going to check in with you to identify a few areas for the retreat in February. So please keep an eye out for that. Today, after voting on the minutes, we'll hear update from Director Allen. And then we will invite our liaisons from several committees to share announcement updates on behalf of the committees. I think we have a few people who want to update the larger board on the work of the committees. We'll have a quick update from the committee members from the committee membership work group. And the Health Equity Committee will present their membership roster for vote and pending approval. We'll discuss OHA's 1115 waiver efforts and review the draft application and formally open up the public comment session for the waiver. And following our waiver discussion, we will have a fairly extensive public comment session today. We look forward to that. First order of business today is to vote on the last meeting minutes. And so we welcome a motion to approve the minutes.
This is Brenda, so moved.
Second, Bill Kramer.
Any discussion of the minutes? All in favor say aye. Aye.
Aye.
Aye.
Any opposed? Any abstain? Okay, great. Pat, I hand it over to you for our director's update.
Great, thank you, Chair Bangsberg, members of the committee. Just a quick heads up. I've got a meeting with our budget co-chairs later this morning, so I'll have to miss the public comment session, but I'll come back and listen to those after my other obligation. A few things to update you on today. First, obviously, COVID and what are some of the current topics there. First, in terms of vaccinations, we've seen pretty brisk uptake in particularly boosters. If you look back over time, our first doses bottomed out in about mid-July. We were doing on average a couple thousand a day of first doses. And then you can see a pretty broad increase in those first doses as the Delta variant took hold. And I think for at that point in the pandemic, for vaccine hesitant people, the fact that it was much more likely, especially in communities with low vaccination rates, to see people that you know or family members get sick or die, helped bring home the reality of the seriousness, particularly of Delta, and that caused vaccination rates, especially in those communities, to go up. Also, we've been in that period in particular, we're doing a huge amount of outreach, mobile vaccination, those kinds of things, reaching out to communities of color and others disproportionately impacted by the pandemic. And I think you also saw that show up in those numbers. That had begun to trail off, but then overall doses began to kick up as boosters became eligible for different populations. And you can if you look at the curve, you can kind of see bumps in the curve that match bumps when new populations became eligible for their first doses, and that has continued to happen. And then, of course, kids became eligible, and we saw a marked but brief surge in first doses, moving up to about 6,500 first doses a day. But that demand has already begun to slack off. We're at about 25% of kids age 5 to 11 vaccinated. It's a little bit hard right now to interpret numbers because we've got some noise from Thanksgiving, and turns out people were more interested in pie than a shot over that weekend, which shouldn't surprise anybody. So we're still kind of coming back out of that and seeing demand pick back up a little bit. But it took a good number of months to get to the 65% rate that we're at for 12 to 17-year-olds. And I would expect that same thing to be true of 5 to 11-year-olds. Meanwhile, booster demand is quite good. We're now up to 20,000 overall doses a day, including first doses, second doses, and boosters. And we've set up a number of, I would not call them mass vaccination sites. I've been using the phrase mid-vaccination sites, 1,000 or 2 shots a day capacity kinds of sites in a variety of areas, particularly again focusing on underserved communities for the locations of those, and we're seeing good uptake there. So I think everything is kind of about where we would expect it to be in terms of vaccination, and as with other waves of vaccination, when new people become eligible, there's a little bit of what I call a Black Friday effect, where everybody rushes the door on the first day, and you get a little bit of chaos initially, but that calms out fairly quickly, and I think we'll see that happen again. Second thing to talk about is Omicron, and I guess what I want to what I want to say is to be clear to say, we know almost nothing about Omicron. And so people who you might hear out there in the media talking about Omicron are engaging in a lot of supposition and speculation. Lots of it is well-informed supposition and speculation, but in terms of what we definitively know next to nothing. There are some emerging data points that are too small and too particular, I think, to want to immediately just automatically say that's what's happening. But those data points seem to indicate that Omicron is more contagious, seem to indicate that it's less virulent, seem to maybe indicate that vaccines continue to be protective. But there are all kinds of challenges with those data points, particularly data coming out of South Africa is coming out of a low vaccination, high exposure rate country with a much lower average age. And all of those things would give you a rather different profile of what disease looks like than a country that's more comparable to the US. There are data points coming out of Israel, which is a very small country. High vaccination rates, almost entirely one vaccine, the Pfizer-BioNTech vaccine. And so we just have to be really, really careful to look at those initial emerging data points and want to assume that that is for sure what's happening. Or when new data points emerge and it turns out that's not what's happening, feel betrayed somehow that, well, they told us X and now it turns out Y. We just have to emphasize that we don't know. We do know that we have not identified a sample of Omicron in Oregon yet. I will be shocked if that doesn't change this week. This week we have ramped up wastewater sequencing for Omicron. We're one of lots of states do wastewater testing for the presence of SARS-CoV-2. We're one of a handful of states that actually sequence those samples to be able to identify variants. I would be shocked if we didn't have Omicron turn up in those or through regular individual sample sequencing that we're one of the top 10 or 11 states in the country for the volume that we do of our samples. So more on that as we see that occur. If and when Omicron shows up, the fact of the matter is what you do isn't markedly different than what we're doing in the face of Delta, which is vaccinations, masking, those kinds of basic protections until we really know more about is Omicron dramatically different in a harmful way than Delta or other variants before it. Let's see, let me spend a few minutes, if I could, talking about digital vaccine records, which you're gonna hear about in public comment today. And I wanna kind of go back just to refresh people's memories, or if you're not familiar with the ALERT immunization information system, just kind of how did we get here generally? Immunization information systems have been around for about 30 years, part of a nationwide effort to create a unified database for vaccines. If you remember back to the 70s or 80s yourself or kids, you had to basically kind of carry around a sheaf of paperwork on your kids' vaccination records. And if you were fortunate enough to have the same pediatrician or family care provider throughout your kids' entire youth, it was easy because they would generate a single paper record for you. But lots of people don't have access to primary care in that fashion, and they would get vaccinations in all kinds of different settings, and it was really difficult to be able to accurately assemble those records. And the big problem was that it created gaps in vaccinations because providers wouldn't know necessarily who had what kinds of vaccines or what was necessary or what vaccines were due. And so there was a big push from CDC to create individual state databases that were linked to CDC for vaccinations so that your provider would be able to go into what we call today the ALERT IIS system and see all the vaccines that you've gotten, regardless of which provider provided those, if it was at a pharmacy or that healthcare provider or some other healthcare provider. And so it helped contribute meaningfully to increasing the vaccination rate, particularly in less well-served communities. And it ended a lot of paperwork hassle for folks trying to manage those vaccine records. Schools also were able to more easily identify who had that required vaccines for school attendance. Fast forward to about 10 years ago, and that system was expanded to include adult vaccinations as we moved into vaccines like pneumonia, shingles, those kinds of things, where adult vaccination has become more common. So today, when COVID enters the picture, COVID vaccines work like any other vaccine in that they go into that alert IIS database so that wherever you've gotten your vaccine, your provider can see that you've gotten it, and you're able to get a record of that vaccine if you need it. As has happened over the last few months, a number of businesses and venues have required vaccination or proof of vaccination to be able to go to events. And vaccines are really effective not only at preventing serious disease, but at slowing the transmission of COVID. And so it's not surprising that an organization like the Blazers, who require proof of vaccine, want to make sure that their staff and their spectators are protected, and that venue doesn't become a source of transmission. So they ask for proof of vaccination. There are a number of ways you can do that: showing the CDC card, showing a picture of the card. But increasingly, there are providers out there that will provide you a QR code that you can show on your phone that will show your vaccination status, and it's got the added benefit of being linked to your actual record, so it's harder to fake than some other tools may be. I got my booster at Safeway, and a few days later, I got a link on my phone with a couple of clicks and was able to put that QR code on my phone, so I've got it there for easy access. And I went to an event over the Thanksgiving weekend, and they asked for my vaccination status, and I was able to show that QR code, and it was super simple. But not everybody is connected to a provider that provides that service. And that's especially true if you were vaccinated at a FEMA pop-up event or other kinds of ways of being vaccinated that are other than through a commercial pharmacy or through your regular primary care provider, especially if you don't necessarily have a primary care provider. Today, you can write it, you can contact us, and we'll send you a written document, but we don't have any way to provide something fast and convenient that could go on your phone. So the project that we're in the midst of is basically doing that, creating the ability to provide not just a paper record to people who want it, but to be able to give them the option, if they want to get a digital record. We're not doing anything in terms of requiring people to get that digital record. We're not doing anything in terms of requiring people to show that digital record. What we're trying to do is facilitate people being able to have easy access to their vaccination records for whatever purpose they want to use those vaccination records for. So I just wanted to provide that context so that people kind of understood how all of this fits into the current system and have that background for the comments that you're likely to hear. Last couple of things to talk about. We've got a short legislative session coming up in February, lots of budget issues, which short session should be about. We'll have a particular focus on behavioral health. I think one of the things we're wrestling with is that the legislature did a phenomenal job last full session of providing resources to help get our previously inadequate system closer to adequate. Meanwhile, the system has collapsed out from under us during the pandemic. And so what we really need to do is to deal with some issues to help build back, particularly residential capacity, but not exclusively residential capacity in the system that has eroded badly through the pandemic for a variety of reasons that are common to healthcare, but are especially acute, I think, in behavioral health right now. Last thing, I think you're going to hear some public comment today, waiver related, having to do with parent providers for kids with intellectual developmental disabilities. This is an authority that's been temporarily granted by CMS during the pandemic, and when the public health emergency expires, it's likely that ability will go away. And so I think you're going to hear some testimony today about wanting to pursue a permanent waiver to continue to be able to pay parents to be the care providers for their kids in certain circumstances. I think that's everything that I've got on my list. Happy to answer questions.
Questions or comments for Pat?
Will the digital vaccination record be mostly just for COVID-19 vaccinations, or will it include all vaccinations for folks?
Right now, it's aimed specifically at COVID vaccinations. Interesting question about whether there'd be a demand for that kind of a mechanism of being able to show your vaccination status, and certainly we could take a look at expanding that access if that's an emerging need.
Ebony, I saw your hand up briefly. To the comment.
No, I never mind. Thanks.
Any other questions, comments for Pat?
Just to follow up comment on the question and response, I think being able to expand it beyond COVID-19 would be great. I'm thinking particularly kids and parents and, folks who do move a lot, who move often. It'd be great for them to be able to have this digital record on their phone, just for making it easy for them.
Yeah, no, I appreciate that, and that's something we can certainly look at. As it is today, it's the databases across the country are linked through CDC, and schools have access to the database, and so that kind of helps obviate the need for carrying around a bunch of papers on your vaccine record, and helps deal with the fact that people move and all those sorts of things. But can absolutely take a look once we get it rolled out for COVID if there's demand to expand that.
Any other thoughts, comments, questions? Thank you, Pat. Appreciate it.
Thank you.
Next on the agenda, we have a few members who would like to give some committee updates. I think Bill Kramer, John Santa, and Ebony Clark would like to make a few comments on the committees they're liaisons for. We're saying that Bill and John's comments are fairly short, and Ebony's may warrant some discussion. So why don't we have Bill and John go first, and then we'll go to Ebony's comments.
Thanks, David. I'm going to be talking about the Cost Growth Target Advisory Group. This is a new group that's been formed that will be actually start operating in 2022. We have a planning group that's been meeting to plan our launch in 2022. Our next meeting is scheduled for, I believe, December 13th. So there are a number of folks here from board members, including Oscar Arana, Jessica Gomez, Kirsten Isaacson, and myself, working along with the staff and several other folks to do this planning. We are planning to host a public hearing in January to launch this. We've been working through the objectives, and we hope to finalize them next week, as well as the agenda. But basically, it's to launch the Cost Growth Target program. A portion of the meeting will be devoted to sharing data on pre-COVID cost trends and what we can discern from more recent cost trends about what has been driving healthcare spending in Oregon. So that providing that foundation of data will, I think, get everybody to a shared understanding of where things, what the situation is, and then will enable us to begin the exploration of potential strategies to address the cost growth drivers and to generate public dialogue. So that's the tentative agenda, or those are the objectives, and we'll hope to finalize that next week and encourage everyone to take a look at our public hearing when we host it in January. I don't know if Sarah is on the call, but if she may have some more details to offer.
That's for me. Thanks, Bill.
Okay, that's it. Thanks.
Thanks, Bill. John?
Yeah, I just wanted to remind members of the board that there's an educational session on Tuesday, the 14th, that focuses on a very interesting body of work done by a subcommittee of the Medicaid Advisory Committee. It focuses on the experience of Oregon Health Plan patients. And I can't think of anything really more important than doing everything we can to see that folks experience healthcare equitably. And so I think that report should launch a discussion among us about what it means and what we can do about it. Thanks.
Thank you, John. Ebony? You wanted to make a few comments on the Behavioral Health Committee.
Yes, hopefully my dogs won't be making too much noise in the background. So I just was gonna just kind of give a high level overview, and I believe that there are some staff, OHA staff though, that I believe at some point are also here to either answer questions or may also give some more in-depth details. If I'm wrong, please let me know. But I'll just jump in and give a quick update. So the Behavioral Health Committee finally launched in November. We have been meeting since November 15th. We've had meeting number 4. We're actually meeting every Monday for a couple hours. And just to do a level set, Governor Kate Brown signed the House Bill in 2086, establishing that there should be the Behavioral Health Committee that really focuses on the quality of services and the transformation of behavioral health services through targeted outcomes, metrics, and incentives. And so between then through this past fall, I know that OHA staff had worked to diligently kind of solicit members. A lot of members are individuals with lived experience, in addition to members who represent various system providers and key stakeholders. And then there's myself, who's the board liaison. The goal of the committee is to improve timely access, reduce hospitalization, reduce overdose, improve integration of physical and behavioral health care, and to just assure that there's actually just a continuum of services that meet the individual and unique needs of the users of our system. Over the last few meetings, we have been working to spend time to kind of get to know who's at the table based on how we identify and what we bring forward from our own voice and perspective. I've appreciated the intentionality around really looking at the power dynamics and really making sure that there's not this imbalance of power based on positions and roles and titles that people hold. Big focus on really kind of making sure that the work is centered by those with lived experience. And we spent several meetings working to develop a charter. I believe we have iteration number 3 that really, again, identifies what our goals are, which are to transform, reimagine, and improve Oregon's behavioral health system, increase quality of services, support the Oregon Health Authority goals, and eliminating health equities by 2030, centering the perspective and input of people with lived experience and communities historically impacted disproportionately by inequitable policies and practices. And then lastly, to identify outcomes, metrics, and incentives that gets us towards real system change that eliminates the health inequities and disparities that we see in our behavioral health continuum of care. So we have 14 voting members and 5 non-voting members. In addition to developing our charter, we're also working to develop some agreed upon values and principles to really guide our work. And there are 2 consultants that are guiding us through this process. And, lastly, because we are at kind of the inception of this work, we're also working to kind of explore and determine leadership such as co-chairs or tri-chairs. So that's what I got. And I believe there's updates on the website.
Congratulations on the success. Any comments from the behavioral health team?
Hi, good morning. This is Kylene Zimber. Thank you, Ebony, for reporting back to the committee. I'm the Behavioral Health Strategic Director, and just really excited to have Ebony join us on this journey. And I will say, and I think you'll probably hear this a lot from a lot of the behavioral health work, we're sort of balancing the sense of system urgency and needing to fix what's broken and get our business done and get money allocated, balancing that against our need to be intentional and intentionally transform the system and focus on issues of health inequities and centering ourselves and being directed by people with lived experience. So we kind of live and breathe that tension every day, and just really appreciate the support from the OHPB and from Ebony in particular for us to take that moment to explore that intentionality, and also the understanding of everyone that we also have really urgent work that we need to do, and just constantly kind of living that dichotomy. So just appreciate everyone's support and understanding as we're moving forward with this. And also would just report that we have a really supportive legislature that is open to what we're saying and really listening to us right now, which is really, really quite wonderful as well, but also an important responsibility for us so that we don't miss any key opportunities. So thank you so much.
Thank you very much. I'd like to invite any other board members to give an update. Brenda, I see your hand raised.
Thank you. Just a follow up to the Behavioral Health Committee's work and questions from our last board meeting. I know we had Director Allen present for us, and there were some follow up board member questions that we did with Tara, and I'm not certain yet where we're thinking or the timing for responding to those questions might be, if now is an appropriate time or if we're going to tackle that later.
Brenda, thanks for that. I did receive some questions from you and another member, and we are sharing those with the behavioral health team. If there were any additional follow-up questions from members, please be sure to get those to me. And we will probably be following up with members offline or with an update at a future board meeting.
Thank you. And with just by way of liaison updates, I'll give a quick note or shout out to our workforce committee. We met in November. We spent some time also on the behavioral health workforce initiative, and I think it'll be important for us to continue to collaborate between these two committees of the board, the behavioral health committee and the workforce committee. We also spent some time really looking carefully, given the workforce shortages that we're experiencing, of course, across the state, across the nation, to spend some time thinking about clinical placement and supervision. So we're doing some intentionality around pipeline development in the workforce. And I've had commissioned a subcommittee basically of the committee to do some really detailed work in that. Their objectives are to really look at clinical preceptor sites and supervision, thinking about the bottlenecks in the system that are preventing student placements, and to be thinking a bit more upstream in our body of work. We also spent some time talking with Dr. Kaz Rafia on the oral health strategies for workforce development, which I think sometimes gets less play in our conversation. So it was really helpful to have him present and share his vision around where we can put some concentrated effort and energy in oral health workforce development. And then also, last but certainly not least, we spent some time on our traditional health worker workforce survey. We learned a lot about how traditional health workers are not equitably placed across the state. Certain parts of traditional health worker and peer support specialists, and there's a different variation of placement for those in terms of those who have registered for that body of work than we might see with birth doulas, for example, or other different types of community health worker designations. And so it was helpful for the workforce committee to start to think about how that might be a real opportunity for us, especially around the issues of health equity. So just a quick thumbnail sketch for this board, and thinking about the committees that you're also liaisoning, if that's a word, with, that we can make those connections often back to workforce and make sure our committee is really well informed with what the conversations you're having as well. Thanks.
Thank you, Brenda. Any other board member updates regarding the committees that are liaisons for? Liaison for two committees, the Health Equity Committee, which has been working on the implementation of SOLG and REAL-D data, as well as working hard on a membership slate, which we'll hear more about today. And also liaison with the Public Health Advisory Board We've been working on our membership bar committee, but also this month we'll be doing health equity capacity training for all the board members. Other updates? All right. I want to thank everyone for these updates and for also functioning as liaisons to the committees to keep a dialogue going between these important committees and the Oregon Health Policy Board itself and the staff at OHA. Today we have the committee membership presentation. I'm pleased to welcome back Susan Otter, who is sharing the membership work group project, who will join us today to provide an update on the work group's progress activities and also present a request to the board members and the committee members. Susan, please start whenever you're ready.
Great, good morning. I'm Susan Otter. I'm the Director of Health Information Technology for OHA and also lead staff on the committee membership project work. And Annette, if you want to bring the slides back up, that'd be great. Today, I'm here to present a request for all board members. We're going around to all of your committees as well, as we're looking at rolling out a standard demographic and sector survey for all committee and board members. And so we are doing the standard presentation for each of the committees. So I'll go through the progress we made or the process we went through for this work, but you've heard about this several times already. So I'll kind of go through that and then talk a little bit more about the survey and where we are in our request. Next slide. All right, go ahead to the next slide. So as you all recall, the Health Policy Board charged the Oregon Health Authority with establishing a committee membership work group back about a year ago to inform and develop a process to ensure diverse and equity focused committee membership across the board's committees, as well as to provide guidance on best practices for committee recruitment and retention and recommendations for systemic changes to support diverse and equity focused committee membership. While we went through this process, we also expanded the scope to include looking at inclusive committee practices, as well as equity work that committees could be doing and starting down those paths as well. So while we focused on committee membership, we also started to look at committee practices. So we went through a process with our health equity consultant, Ignatius Bao, as our contractor to go through an environmental scan, root cause and gap analysis, and then conduct a series of interviews. He conducted about 50 interviews, about 30 of which were with external partners. The majority of those were with community partners, and also there were interviews with healthcare industry partners. And then other interviews were conducted with the policy board members who are sponsoring this work, as well as staff and leadership in OHA. We presented the final report in the October board meeting and wrapped that up with a kind of final polish and delivered that at the end of October. Next slide. So we really prioritized the recommendations of this work based on the external partner feedback. And so we always want to start with what did we hear from our community partners and other external partners that we need to do differently with committee work. So this is the highlights from the external partner recommendations. The first is around needing to engage in authentic community engagement and build trust, and even before we work on committee membership recruitment. We also looked at heard supporting recruitment with improved information and coordination. Many community groups don't have easy access or aren't immediately familiar with all of the different committees that we have, and needing to go to a website to find out about a recruitment was not sort of the most friendly and opening way to work with our community partners. We heard the recommendation to collect and report granular, disaggregated, comprehensive demographic data about members and applicants, which we'll talk more about today. And then to work to intentionally support retention of diverse committee members as they're joining committees and needing additional support, orientation, and and potentially financial stipends, et cetera, to support that retention. Looking at system changes, such as changes to charters and statutes, term limits, and assessing the power dynamics around committees to work on as they work on health equity. Ensuring that committees are safe, welcoming, and inclusive. Of course, that committee meetings are accessible. Implementing more inclusive practices, including improving public comment and decision-making practices, and supporting staff and committees with training and other tools. Next slide. So these external partner recommendations really informed the 4 overarching recommendations of the final report. And so each of these 4 recommendations has a series of sub-recommendations, and which we'll be working on implementing. So here you can see the 4 recommendations really do reflect the recommendations I just went through from the partners, looking at engagement as a priority to work with diverse, underrepresented, and excluded communities. We have a set of recommendations around supporting recruitment and retention, implementing inclusive meeting practices, and then implementing committee work on equity. Next slide. So today I wanted to talk about the member survey. So the purpose of our member survey is to collect standardized information and be able to report on the demographic and sector and experience of committee members and applicants. What we found in doing this work was that each of our committees collect data differently. We don't always ask about health equity experience, lived experience, or what we're calling cross-cultural experience. And you can see here, we're talking about cross-cultural experience as experience working with populations and communities different than one's self-reported identity, such as volunteering or with a community living in a different country, working with racially or ethnically diverse populations and communities that are different than your own lived experience and self-reported identity. So what we found is we don't have this information to be able to bring to the board across your committees consistently of what the demographic, experience, and sector representation is across committees. So we worked on creating a comprehensive member survey. The survey questions you can see in the box there include a question about health equity, expertise, lived and cross-cultural experience, race, ethnicity, language, disability, sexual orientation, gender identity, and then geography, sector, and age. We pilot tested this draft survey with 4 of the board committee recruitments: the Health Equity Committee, the Cost Growth Target Advisory Group, the HPQMC and Metrics and Scoring Committee recruitments. I know you'll hear later today about the results of the Health Equity Committee recruitment. In pilot testing, we requested that folks who completed the survey fill out an evaluation. We received 46 responses, which were largely positive. We heard from committee applicants that they felt like questions about lived and cross-cultural experience helped them feel their voice would be valued as members of the committee. It increased confidence that their voices would be heard. One person said that they felt their lived experience and professional expertise both hold value for the committee, and reminded them that we wanted them to bring both of those elements to their work on the committee. So this is the pilot test also showed that we had work to do to improve the clarity of some of the questions that we asked. We made changes to the health equity question, the cross-cultural and lived experience question in our updated survey, which will now be rolling out to you and all the members of your committees to gather baseline data. We'll be still testing this survey. We think we might still have work to do. So as we roll out this survey to the policy board and its committees, we'll also ask folks to complete an evaluation and let us know if we've improved on the clarity of the questions and get additional feedback. Once we're done with that baseline data collection, then we will revise the survey a final time and roll it out for future member recruitments. Next slide. So this just shows our timeline where we've been pilot testing. We're doing the baseline data collection now. We'll be supporting that baseline data collection with presentations like this one to each of the committees. There'll be an educational webinar on RealD for the board and its committees and members of the public to better understand why we're asking those questions, in particular for board and committee members. We've received community feedback. We'll also be sharing the final survey with the community members that were interviewed for this work. And then we'll be summarizing the results and presenting at the February board retreat. Other work that we're undertaking for this project is working on developing staff guidance to implement consistent and inclusive committee recruitment and committee practices, and beginning to look at legislative considerations where we have committee charters that are set, or committee membership that's set in statute, where we might want to consider making changes in the legislative session. So more to come on those pieces. The last piece is just our request for you. We'll be sending an email to each of the board members and each of the members of your committees with the survey and information about completing that. You'll receive that, and then this week or next week, the survey will be available online to be filled out. We'll also attach a paper copy for folks that want to use a paper copy. Sorry, could you go back to that slide? And let's see, I think that was it. And we'll ask you to complete the survey within about 2 weeks of receipt. And then you'll also receive the evaluation survey for folks that complete the survey. We're really looking forward to getting additional feedback. One other thing I wanted to mention is when we report on the results of the survey, we report in the aggregate at the committee level. We'll also be rolling the data up for all the board committees for the February retreat. So I will pause there and see if folks have any questions about this request or the work.
Thank you, Susan. Any comments or questions from the board?
I suppose just it's a quick comment of gratitude. I'm so pleased that we took this issue really seriously, and I thank you so much for the detailed report. I think we're on track. That's it. Thank you.
Great.
I agree with Brenda's comments. I did have one quick question. I felt like in some earlier iterations, there was discussion about how we kind of coordinate committee recruitment. So the long list of committees aren't each independently asking. Is there any, is that still part of the plan? Any progress on that front?
Yes, absolutely. So, you know, historically, each committee staff is sort of operates somewhat in a silo in their committee recruitments. So we are working towards a better coordinated committee recruitment process, including bringing on additional staff resources. We're also sharing committee applicants that might be good leads for other committee work if they're not selected for the committee they applied for. When we roll out the kind of consistent committee survey that you'll see, we'll be asking folks if they might have interest in other committees as well. So we're trying to capture that. And then we're working towards better basic orientation about what the committees are, what the ask would be. So we can post in one place all of the committees that are looking for members or might be looking for members in the future. So there's a number of things that are underway.
Thank you, Susan. Any other comments or questions? All right,
Just thank you, and I look forward to hearing more about the results at the February retreat.
Very good. Thank you, everyone. Thank you, Susan. Look forward to hearing more. Next, Leanne Johnson, the OHA's Equity and Inclusion Director, will join us to speak about some of the work of the Health Equity Committee, particularly its proposed membership slate. As the liaison for the Health Equity Committee to the board, I followed this work closely. been very impressed with the very intentional work that the committee's done, both in terms of recruitment and review and discussion of committee members to come up with, I believe, is a diverse membership roster that represents many intersectionalities, and really want to thank every member on the Health Equity Committee and Director Johnson for this work, and look forward to the presentation discussion of the board. Director Johnson.
Thank you. Thank you, Chair Bangsberg. Appreciate the opportunity to be here and share about our slate and the process by which we got to this point. For the record, my name is Leanne Johnson. I'm the Director of the Equity and Inclusion Division for the Oregon Health Authority. And happy to entertain any questions along the way. I've got this information before you now, as well as a PowerPoint presentation. So you are very much aware of the OHPB definition of health equity. And we so appreciated the support in the process of developing this definition, and more importantly, the fact that it is referred to and it is used over and over again as a foundation for the work of the Oregon Health Policy Board, quite clearly the work of the Oregon Health Authority, and we get quoted quite often in the legislature as well around our definition, as well as the goal to end health inequities by 2030. So the traction is very much appreciated, and also want to do a specific thank you to Director Pat Allen for the support that we've gotten in this work. Since he's come on as our agency director, we have moved in leaps and bounds. Not to say that there hasn't been resistance, because there has, of course, been resistance from the system itself, but we've been really able to rely upon the Oregon Health Policy Board and OHA leadership and the legislature and the governor to continue to make way for this work. So we thank you very much. So today we have, we're going to propose a slate for the Health Equity Committee. I will start by saying on this aspect of it, we had 33 candidates from across the entire state, most of the state. It was a difficult decision to drill down to 10 because there was so much of the lived experience and the cross-cultural experience and the industry experience. So we're really fortunate to have had a tough decision, I would say. I would take a tough decision any day, and quality over the opposite of that. So as you know, the Health Equity Committee was established in 2017 by the Oregon Health Policy Board, and our purpose is to coordinate and develop policy that promotes the elimination of health inequities and the opportunity for health equity for all people in Oregon. The committee is comprised of 15 people that are experienced and skilled in a variety of areas, including, of course, most importantly, health equity, as well as industry experience and experience in the health system. So I'll move into the PowerPoint. So here I've just mentioned about the Health Equity Committee. Next slide, please. Thank you. Thank you. Thank you. And then specifically in the charter, and I know many of you are aware of this and wanted to do a little bit of review, especially for newer members of the committee, that the Health Equity Committee has very specific duties that are put forward in the Charter of 2017. First is to provide analysis, guidance, and recommendation to the board, including not only key legislation, but other policy as well, using what we now are calling an equity framework. It says equity lens in the charter, but we really are focusing per the Health Equity Committee on a framework and a very foundational way of moving our work forward from the beginning and not as an add-on. The committee provides assessment and actionable recommendations. We've seen that in process and in play with the 1115 waiver, with crisis care guidelines and a variety of other areas as well. This committee has been extremely vigilant and diligent and thoughtful in their work. The analysis of data and information to assess our progress towards achieving health equity and how we in OHA become a more culturally responsive organization. As a part of staffing this Health Equity Committee, we in the Equity Inclusion Division also reap the benefits of their expertise and their knowledge of the broader health system and broader communities in the state of Oregon. And also the goal of this committee is to work collaboratively with other Oregon Health Policy Board committees to be a resource and serve as a leader for meaningful change in the health system. And we'll be seeing more of this as time progresses. We've appreciated the collaboration with current committees and all understand that needs to happen at a much more upfront from the beginning and much more collaborative way. Next slide, please. So the focus moving forward, what the focus has been, I should say, for this committee, as you know, and many of you know, that we had the opportunity to help create lines of communication between the committee and the communities. The Latinx community-based organizations shared regarding COVID-19 response to this committee. Also LGBTQIA+ community-based organizations shared also with the committee on the need for greater access and issues of bias and discrimination that we need to be addressing for the communities. Strengthening collaboration between the Health Equity Committee and other committees, which I just mentioned, that moving forward is going to be much more of a focus. This last year, we were able to, thanks to you, add age to the health equity definition. We appreciate that meaningful conversation and the fact that that came from community, and we were able to be responsive to that. Support of the OHPB guidance and development around the 1115 waiver, which I've already mentioned. The engagement and the policy development has been a critical piece of the work, and around the Health Equity Committee and the waiver. And also more recently, engaging the Oregon Health Authority Behavioral Health Equity Team to pave the way for more collaborative work. And we now have a Health Equity Committee member who is a member of the OHA Behavioral Health Committee. So that is a recent development. Next slide, please. So let's talk about the recruitment and the slate. As you know, and you heard from Susan Otter just a bit ago, that we have been participating in leading along with health policy and analytics, been leading together, co-leading, as well as with external relations division, participation and the work of the diversifying and providing a much stronger equity foundation to all of our work. We've participated as subject matter experts. I've participated as an agency sponsor along with Don Jagger from External Relations, who is also our chief of staff. We as a result, and you also heard from Susan Otter, were able to, in this recruitment of our Health Equity Committee, this round, we're able to align with this much of this work, which we were able to not only reap the benefits of it, but also inform the process as well. We did perform a gap analysis. Members of our team, Equity and Inclusion Division, performed a gap analysis to determine what we needed for this recruitment for the full slate of members. And so that occurred. And in particular, we noted the need for members of the LGBTQIA+ community and people with disabilities community, as well as healthcare services providers and community-based organizations. And we always, of course, are keeping in mind the geography throughout the entire state and the differences that exist within the different regions of our state. So we were able to use the recruitment. It was used as one of the pilot opportunities, as Susan did report. And we were able to also be a part of that assessment of what individuals thought of the process of, and you've already heard those outcomes of that. Pardon my voice, I'm a bit weak today. Thank you. Next slide, please. So when we set out for this round of review and recruitment and review, I would also want to stop and thank the members of the Health Equity Committee that were part of the Recruitment and Review Committee. That we always keep in mind our overarching priority populations that we are to be of service to, and who are to be informing us, more importantly, our role as an agency is to follow the lead of community, because that's where we understand the narrative and the stories of what people are experiencing, and that's where we can better get to a point of interventions that will truly help us reach our goal of strategic goal of eliminating health inequities in 2030. So communities of color, tribal and indigenous communities, and immigrant and refugee communities are part of our priority populations. Having experience with disability community or being a member of that community, as well as LGBTQ plus communities. Very important to a point made earlier, experience as an Oregon Health Plan, OHP member is critical experience in the health delivery system. And first and foremost, though, for all of us, we want to be sure that we are improving health inequity and eliminating the inequities in our system. Next slide, please. So this is the new member slate that we are proposing, and hope that you will accept this slate. We are in an interesting predicament of having a high turnover at this point of time. We've got a variety of members that I will mention next that are leading, who were really the beginning members, the founding members of this Health Equity Committee. So it's sad to lose that knowledge and that thoughtfulness and expertise and wisdom. And at the same time, we're very excited that we were able to forward a slate of these 10 individuals with the hope that you will accept them as new members of the Health Equity Committee. So that's our proposal for today. You can see, I hope, that the slate that's in this right now. I'll give a moment so you can read through those. And I believe you also did receive a document that had much more information regarding credentials, experience, affiliations. And just to note that because we do have affiliations here, but the members are not representing the organizations that they are affiliated with. This is just to give you a sense of what organizations these individuals work through, because that does indeed speak to experience and wisdom. Next slide, please. So we also are fortunate that we have 5 members that are renewing, and you can also, of course, see here on the slide those members as well. We are pleased that we will have some continuity, as well as new infusion of energy and expertise. Next slide, please. And then the sad downside of it is the members that we will be losing, and you recognize, I'm sure, several of these names of people that have come before you and spoken quite passionately from a great deal of experience and expertise. And so these are the members that we bid farewell to, and very much appreciate all that they have done to provide the foundation and the grounding and the move forward, appreciative of their, I can't think of the word I want, but just always being extremely candid around their position and helping us move our work forward. So we are losing Dr. Derek Dubivier, who has served as our one of the co-chairs the past 2 years, Carly Hood-Vonick, who was one of our previous co-chairs, one of the first co-chairs, Joanne Miller, who has worked throughout the system around equity through as an industry expert, Wesley Viday, who has worked as a public health professional and also has provided expertise related to the experience of people with disabilities. And then Michael Anderson Nathy, dogs are about to bark, I knew it. Michael Anderson Nathy, who is also one of the first co-chairs of Carly Herdronic, and is an expert in equity-related, health equity-related matters. Next slide, please. Oh, okay. Well, that's luckily we're at the end, just as the dogs start to bark. I'm happy to take questions. I will. Good job. Good job. Yes. I just want to reiterate, we had a strong poll. It was a tough decision. And I will stop there.
If it makes you feel better, Leanne, my dog joined in sympathy.
Oh, good. I'm so glad I could do that for you, Pat.
Ebony, I see your hands raised.
Thank you, Leanne. This has been a very thorough, detailed report out. Appreciate all the thought and attention, and excited to see that there was such great interest. And, it's a good sign when, you have an overwhelming amount of interest where you gotta like, what are we gonna do? The one question, just out of curiosity, is what percentage of the membership are just are users, consumers of organ health plan versus folks who may actually work in a specific provider situation or organization, understanding that they're not necessarily representing organizations, but do you know what percentage is purely just kind of a consumer or user of the system?
I appreciate the question, and I don't know at this point. I could certainly get that information for you unless there's someone from our team that has that answer.
Yeah, I have that answer. It's 20%.
Maria. Thank you, Maria. 20%. And I want to thank Maria for all of Maria's work of managing the committee and managing this this whole recruitment process and knowing the details.
Other questions or comments?
Just a comment and also a question. So yeah, congratulations on getting to presenting another slate, another great slate with really amazing and talented individuals. Congratulations on having such a robust group of applicants as well. That's always really exciting to hear when there's so much interest in being involved in these committees. I have a question out of curiosity. When I was looking at the slides, I saw that the application process looked like it opened towards late September and then it closed October 9th. And I was just curious if you did anything prior or leading up to the opening of the process to be able to have such a great result in terms of the number of applicants, because it sounds like it's a fairly short window for applying to the committee.
I will start, and then if Maria has anything to add. So thank you very much for the compliment. We appreciate that. And what I think one of the opportunities that we've had that maybe other committees don't have, because we are stated as being and working as a health equity committee, I believe that in and of itself creates an advantage, first in getting a much more equitable and diverse interest of people and application of people, as well as it's a topic that is so very rich and ripe for attention right now, that in some ways, and this is not to take away from any work that was done, but in some ways it does sort of recruit itself to, in many respects. And that, once again, is not to take away from the hard work done by our team members. And Maria, if you have anything else to add, we'd be more than happy to hear what you have to add to that, if anything.
Thank you, Leanne. Thank you, Oscar, for your question. Actually, Leanne is right. We have the benefit of being a very community-facing, community-oriented committee. So our application generated quite a bit of excitement when we opened it. A couple of things, we are always recruiting. So every opportunity we have to talk about the Health Equity Committee, the role of the committee, etc., it's an opportunity for us to recruit. We always have a member intake form in our website, by the way. So it's we had around 17 people that throughout the last years have manifested interest in serving. So the first people that we reach out to were those 17 people. So we send applications to them so they would consider. And also I can't stress enough the incredible role that our members, the committee members had on our recruitment. They actually forward, applications to members of their networks, with the special recommendations, please consider applying. This is a great group. So I can't stress enough about the important role that boards and committee members have on recruitment.
And as someone who's watched the process as liaison, I think it, has been an excellent example for other committees in terms of a process of recruitment, review, discussion of members, and I think it's been great to follow. I've learned a lot, so I really want to compliment everybody in Health Equity Committee and Director Johnson for leading this effort.
Yeah, thank you both so much. And then just a really quick comment and potential idea. Just wanted to thank the outgoing committee members for all their service, their years of time and dedication and service on the Health Equity Committee. I know that many of them, started from the original slate and led to did a lot of great work on the creation of the Health Equity definition that is now adopted by the policy board and OHA. So I just wanted to thank them all for their time and their service. And hopefully, there's a little bit of maybe there's a possibility to somehow keep some of them, whether it's on other committees or try to transition them into other committees. I know that some of the other committees are looking for committee members with health equity experience. So just a thought.
Good idea.
Can I have one more
Go
follow-up?
ahead, Ebony, go ahead.
Just a statement, and we can kind of continue the conversation. I think again, I'm trying to hold myself accountable to the values not only of OHA, but also the values of the Oregon Health Policy Board and just the work I do. And again, we know that it's important to be client-centered and consumer-driven. And so just a technical piece that I want to put out there, and I think y'all will get used to me asking and saying this every time this is relevant, but just wanting to make sure that as we talk about individuals with lived experience based on who's represented, again, how do we also clarify what that lived experience means? Does lived experience mean someone who's been on the Oregon Health Plan in general? Does it mean someone that has been a user of specific services and supports? The other piece is how do we also assure that we are seeing that value and the through lines and even contractors that we hire. And so, whether it's, contractors and or just committee members, how do we create that equal balance and priority of individuals with lived experience versus those who have no also financial conflict or interest or things like that. So I just wanted to just kind of put that out there to just always say, because that's something that I work in my everyday life to go a step further to define what I mean by lived experience, whether it be, user of the system, lived experience based on, how someone may identify from a racial perspective, so on and so forth. So thank you.
Thank you.
Thank you, Ebony. Any other questions or comments before we move towards a vote? Okay. To entertain a motion to approve the membership slate for the Health Equity Committee.
So moved.
Moved. Do I hear a second?
I second.
Second. Any further discussion? All in favor? Aye.
Aye.
Any opposed? Any abstain? Great. So the membership slate is approved unanimously. Thank you very much, Director Johnson, Maria Castro. Thank you so much, and the work for the committee, and also I'd like to join Vice Chair Rana for thanking all the members who contribute to the committee and are stepping off, and thank them for their service.
Thank you. And we'll be having a send off for those members at our upcoming Health Equity Committee meeting, just so you're aware of that. And now that the slate has passed, I want to really underscore Maria's work on this. I wanted to always be the one who's taking any criticism up front if there's criticism. And now that we are through the slate, I just want to, this would not have happened the way that it did without the leadership of Maria Castro. So I want to really underscore that. Thank you.
Well done. Thank you. All right. Well, we're doing well on time, and we're scheduled for a break. So it's about 10:50. Why, or 9:50? Why don't we rejoin at 10 o'clock? So look forward to seeing you all at 10 o'clock, where we'll have a discussion on the 115 Medicaid waiver. I'd like to welcome everyone back. Welcome back. And I'd like to welcome Jeremy Vandehey, who will do our formal kickoff for the public comment period for the 1115 waiver, and also give us an update of where the waiver application is. So Jeremy.
Great, thanks, Chair Bingsberg. I'll be flying solo today. Lori ended up unfortunately having a conflict, so you're all stuck with me today. We've got about 15 folks signed up for public comment. I think we should have plenty of time for Q&A. I'm on the board and still public comment, but it's good thing we're running a little ahead here. So I'm going to give a brief history of the waiver. Talk about what's proposed in the application, where we are in the overall timeline. And then we'll move to public comment at the end. I want to go to the next slide. And one more. So we are now, after a year of work plus, entering really the final stage of public comment in the waiver process. There's a draft application was posted last week. We'll be collecting public comment throughout the month. Making any revisions in January. We'll also be doing tribal consultation during that period, and then posting in February. We're working really diligently to really create a process where we're tracking individually every single public comment and responding to that, both for purposes of be responsive to CMS and as well as to the public. So when we get to the end in public comment, we're asking that folks make sure that they state their name, what their public statement is. We'll make sure that we capture that verbatim. If they represent an organization or interest, to please indicate that as well. And on the survey online, we're also collecting demographic data that's confidential, that will allow us to see what type of public comment we're getting and from whom. Next slide. We have a website that has all the documents online. Here's the link. As I mentioned already, we'll be actually capturing all the public comments through the public comment period and putting those on exactly as written or stated, as well as who made the comment and who they represented, if not themselves. And then we'll be responding on how each comment is incorporated into the final application. And this is to really both be responsive to public and also to demonstrate to CMS what changes we made and what those are being responsive to. Next slide. I know this is great, thanks. I know this is a little bit of background, but just in case folks are tuning in who haven't been paying attention to the previous waiver webinars, the waiver renewal process is a process we go through roughly every 5 years with CMS. We've had a waiver in Oregon for our Medicaid program since 1994. We actually have multiple waivers with the federal government, including multiple 1115 waivers, as well as a bunch of waivers related to long-term care that are a different type of waiver, and waivers related to substance use treatment, which is a separate waiver. The waiver we're really talking about today is one that really dictates how we run the Oregon health plan. And it's only one part of our overall basic agreement with the federal government for how we run the plan. Most of how we run the Oregon health plan is contained in something called a state plan that we update on a monthly basis. And anytime we want to make changes to the Medicaid program that are within the bounds of what's allowed under federal law, we do that through the state plan. But every 5 years, we have an opportunity to try to color outside the lines if we want. If we want to do something not normally allowed under federal law, but that we want to test or pilot, that we think will improve overall the program for those that it serves in Oregon. And so the waiver is a bit confusing because it's a very comprehensive document describing how we run the Medicaid program, but really what it's aimed at is specifically some regulations that we're asking the federal government to let us not be aligned with. And so the purpose of the waiver while it describes our overall program, isn't to capture every detail of the Medicaid program. It's really to describe why we want to run our Medicaid program a little bit different than what's outside the normal bounds. Next slide. Inherently, this is a negotiation with the federal government. Whether to grant a state a waiver or extend a waiver or evolve a waiver is really completely at the discretion of the federal government. And so it's sort of a mix of policy and politics, of trying to bring forward some things that we think will improve the program, but also trying to align those with whoever's running the federal government and what their priorities are. We feel very, very well aligned with what we're proposing in our early conversations with this administration, which is good news. But there's a whole number of things that they factor into when deciding whether to grant a waiver, including the precedent it creates and their own bandwidth to manage a waiver, and whether or not they've got concerns or whether they've got other priorities. So there's a whole bunch of things that go into it. And generally the way the process works is we will apply, and then we will get into months of negotiation and back and forth of them trying to understand why we're proposing something and what the impact is, and what we get out on the other side certainly will look different than what we go in with. And that's just a part of the process. Next slide. Overall, the timeline we've been on, we've been working at this since late 2020. We'd actually, Lori had just kicked off a presentation to the OHA leadership team, trying to really get out ahead of this back at the end of 2019 and early 2020, and then COVID hit and slowed us down. But we got things moving again at the end of last year. Started first with really establishing the vision for the waiver, really decided through conversations with the policy board and the governor and legislators who have been working on this, that this is really advancing health equity needed to be front and center. And then from there have built out a number of priorities that I'll talk about. We've gone through multiple rounds of public comment and gathering input from a variety of folks. We've gone through 2 iterations of developing concept papers, one set that came out in June and a second set that came out in November. We've been meeting with our tribal partners throughout the year on a monthly basis, and we'll be going into formal tribal consultation. And we've been collecting public input on those concept papers and input from a variety of committees, including the policy board and health equity committee, legislative work group, CCO committee that we had stood up, and others. Next slide. Our overall timeline, as I mentioned, we're now in formal public comment for the application in January. We will be making any changes reflective of public comment and our work through tribal consultation. We'll expect to submit the final application in February. And from there, the way the process generally works is CMS then starts to assign subject matter experts to work with subject matter experts within OHA. They'll start to get into a process of weekly or biweekly or monthly meetings where they're really trying to understand why we're proposing what we're proposing and what the impact would be. And through those conversations, that's where sort of the negotiation happens, where you start to figure out where they're willing to go or not willing to go. Our current waiver expires at the end of June. We've worked out this timeline with the current CMS leadership. Expect that we'll likely get a short-term extension from June to carry us through the summer and to fall, and expect to have the waiver in whatever form it comes out approved by before the end of next year. And then from there, we'll move into implementing it. Some things we'll likely be able to implement as early as the following year. Some things may not start till the next 5-year CCO contract, really depending on how complex implementation is. Next slide. Just to kind of tie together and the difference between the concept papers and the application. The concept papers that came out were really intended to capture the new things that we wanted to do and sort of the vision and the why. The waiver application itself is a much longer document, and there's a couple of reasons for that. One, there's a bunch of more technical details that have to go into the application that great for the concept papers. Like I said, we were really trying to get ideas there through the concept papers and get feedback, but we have to do all sorts of things like budget neutrality calculations, in the application. The second piece of it is anything in our current waiver that we want to continue. We need to explain that. We need to explain why we're going to do that. We didn't focus on that so much in the concept papers. We really focused on the new things, but there's a lot in our current waiver that really helps us run CCOs the way we run them. And we want to continue those. So the application itself covers both things that we want to continue from our last waiver, as well as the new things that we want to do. Next slide. The 4 concept papers and 4 big priority areas are captured here of really how we think the waiver can help us really advance our health equity goals and our 10-year goals as an agency to eliminate health inequities. And there's 4 main buckets that I'll go through. First is how the Medicaid program and the Oregon Health Plan can really help us as a state achieve our goals of getting to universal health insurance coverage and ensuring that more people who are eligible for the Oregon Health Plan can get in and stay in more easily. Secondly, expanding when and where Medicaid can cover services to help individuals as they're moving through different life challenges, different life events, and transitioning between different public systems. The third is around continuing to promote more flexible spending, more flexibility for and how we pay CCOs to promote population health and improve value. And then the final one is requesting some additional financial investments from the federal government that we think will really help us specifically address equity. Next slide. It gets a little confusing. The waiver application itself needs to be broken down in a little bit different format to cover, as I mentioned, those things that we have to describe in the application that are beyond what's in the concept paper. So what you see in the application is both the concept papers, but also we have to go through and describe a number of things, including eligibility changes, who's going to be covered, any changes to covered health plan services, any changes to who we would pay in terms of providers, changes on the quality metrics that we use, budget neutrality. We have to be able to describe that in the whole, this waiver is not going to, and the things we're asking for, it's not going to cost the federal government more than what it would cost them to cover Medicaid in a traditional sense without the waiver. And we have to be able to describe how we're going to evaluate our work on this. These are really intended to be demonstrations. And so a big part of this is describing how we'll evaluate whether the things that we're doing actually do improve health and outcomes and help contain costs. So as people are tracking, just recognize we have to kind of move to a different model of how we're talking about things. Next slide. So I'll start to go into the 4 areas and more specifics, starting with coverage. Next slide. And one more. There's really 3 big things that we're asking for in terms of coverage. And our overarching goal here is to get more folks who are eligible in, keep them in, make it easier for them to remain covered and not get kicked out for things like a change of address or having to go back through the application process, which is tedious and confusing. We know that one of the top reasons that folks indicate that they're uninsured in Oregon is because they lost their Oregon Health Plan coverage. And we know by the self-reported income data, they tell us that they're actually eligible still. So we're trying to remove those disconnects and get more people in. So 3 things we'll be doing. First, asking that kids can stay enrolled up until their 6th birthday. Just such a critical part of early years. And want to make sure that kids in those first 5 years really stay connected to their primary care provider and have all services needed to be kindergarten ready and off to a good start in life. Next slide. The second area is for everybody else, moving from 1-year continuous enrollment to 2-year continuous enrollment. And the idea here really is to really as Pat likes to say, not kick people out just for not filling out their paperwork, even though they're still eligible. We know that there's a number of folks whose eligibility is teetering, and we want to make sure that folks can stay in if over a longer period of time. Most likely they're just going to be in the Oregon Health Plan and make that easier to stay in, and reduce the number of times that folks have to fill out the paperwork and potentially lose coverage. Next slide. The third area, and this may or may not ultimately need to be a waiver thing. We're having, I actually just had a conversation this morning with CMS around, there might be a path to getting here without a waiver, but we're going to be asking that we can use SNAP income verification for Medicaid income verification. They're both means tested. They're both based off of income, but folks have to go through two different application and income tests. And in essence, what we want to be able to do is if people are deemed eligible for SNAP and their income is verified and their income would indicate that they're eligible for Medicaid, that we create a streamlined process where they can automatically get enrolled in Medicaid. We've just done some work on this, and we think there's potentially probably somewhere in the bounds of about 80,000 people in SNAP who aren't enrolled on Medicaid. They may not all be eligible due to things like immigration status or documents. So we don't think all 85,000 would come in, but just to kind of give you a scale of the number of folks who potentially are actually eligible, but may not know that they're eligible for Medicaid and could come in. Next slide. So what does this mean for members? One, we want to make it easier to enroll for programs that they're eligible for. We want to make it easier for them to stay enrolled for programs that they're eligible for. We want to reduce the number of touches and application processes that folks need to go through in order to get services. We want to really address what we call the churn population, folks whose income is going up and down on a fairly regular basis, and they're technically bouncing in and out of eligibility for Medicaid, and having a huge disruption in their insurance, and try to really stabilize coverage for those folks. Next slide. Next slide. So the second area is around improving health outcomes through streamlining coverage and providing expanded coverage as folks are moving through different life transitions. I would think about these in sort of two main buckets. One, folks who are transitioning through different public systems where traditionally Medicaid can't provide services, and folks who are going through experiencing other life events where they could really use some wraparound services or access to some of their services that traditionally Medicaid doesn't cover. So the first element of this is providing some Medicaid services to folks in prison, or I should say coming out of prison, and folks in local corrections, youth in the juvenile delinquency system, folks coming out of the Oregon State Hospital or psychiatric residential treatment. In terms of local corrections and youth in the delinquency system, we're asking that their Medicaid coverage continue. For folks coming out of prison or the Oregon State Hospital, we're asking for a limited benefit package that really allows CCOs and the state to start working with those individuals, do some discharge planning, get them connected back to their primary care provider, make sure that they've got drug treatments or other things ready to go, and just reduce the number of things that they have to do once they're discharged and trying to transition back into the community. Next slide. Secondly, we're going to be asking that we expand eligibility for special needs youth up to age 26. This is really to address the huge shift in what's available and lack of behavioral health services, especially, but lack of additional services for folks when you move into the commercial insurance market. While we know we've got a lot of challenges around behavioral health at the Medicaid, it often looks even more bleak in the commercial space. And so for kids who have special needs, want to be able to expand their Medicaid coverage for longer and not have such a hard drop off at the age of 19. Next slide. So those are kind of folks transitioning between systems. We also want to expand coverage for folks to be able to access services that are not just traditional healthcare services, or non-traditional healthcare service, medical services, I should say, for folks facing a number of health challenges or other life events impacting health, especially looking at housing-related issues and climate change supports. And Brenda, I really appreciate you brought this up before. While this isn't, I would say, driven by a major behavioral health strategy, that we really think this is complementary to what we're trying to do around behavioral health. This will obviously serve a lot of folks who are dealing with behavioral health issues and moving between systems. So we see this as a really complementary strategy to all the other work happening around behavioral health. But we'll specifically be looking for more defined set of services around tenancy and to address homelessness, services to help transition folks as they're coming out of jail or prison, kids as they're entering or leaving foster care. Also looking at some climate specific things, including transportation to cooling centers, AC units, things of that support that are kind of, wraparound social supports for folks that are critical for their health. But right now, in order to access, often have to go through a pretty tedious application process with the CCO. Next slide. Additionally, we're going to be asking for expanded use of traditional health workers and others, including peer support specialists. Largely, access to these services or these providers has to be tied to a treatment plan that happens within the medical system, and we want to make it more easy for folks to have access to these providers without needing a treatment plan. We're also going to be asking for some additional federal support for child welfare to be able to help with ensuring necessary capacity for psychiatric residential treatment services for kids in custody. Next slide. What this means for Medicaid members. At the end of the day, what we're really trying to do is break down some of these hard lines between where Medicaid can cover and where you can't, and recognize that we're trying to, at the end of the day, keep folks connected to their key providers, to their primary care provider, to their behavioral health provider, as they're moving from between systems or moving between eligibility or other life events, trying to reduce the number of disruptions and smooth coverage and connection to the healthcare system, as well as provide more services that are outside of medical services that are critical for health. Next slide. The fourth area is around changing how we and continue to evolve how we pay CCOs, and really trying to continue to promote a payment model that supports population health. Next slide. Next, let me go to the next one. So a couple of things that we're proposing in terms of evolving the rate methodology and how we establish global budgets for CCOs. We're really looking for flexibility to look back farther and set a budget that goes forward for a longer period of time looking forward. And we're going to be asking that we can look back at experience over the last 5 years, really set a base population-based payment for the CCO, and then trend that forward at our cost growth target with the ability to go in and make adjustments as necessary if it's not enough money to cover folks, but really have this look and feel much more like a budget that's over a longer period of time, and the idea to really promote more investments into population health and to get out of the tedious annual rate making cycle where you spend most of the year trying to look at what you spent last year and build a rate for next year instead of making investments where we'd like to see them. We think ultimately this will be simpler, more predictable, and hopefully shift more of the focus upstream into population health. Next slide. We're also asking for some flexibility around coverage of prescription drugs. This has been a huge challenge, as you all know, for years. We're proposing something similar to Massachusetts proposed a couple of years ago, to be able to have a closed formulary in certain drug classes where we could be able to potentially negotiate a better deal with the federal government. I'll be totally honest, I think it's pretty unlikely that we actually get this. We're not really clear where this administration wants to go in terms of prescription drugs. They've been wholly focused on the congressional conversations, and so don't really know right now what they would or wouldn't be willing to do with states. But as we're trying to move towards a statewide cost growth target, would like to have some more flexibility in terms of how we can manage drugs. Next slide. Next slide. The other component of how we're changing how we pay CCOs is the quality pool. Right now, we pay about 4.25% of CCOs' global budgets each year based off of meeting targeted improvements in quality. We've seen huge success in this program. It's been one of the key drivers of change and transformation. One of the challenges we've had, though, is that underlying inequities and disparities within those quality metrics have largely persisted over the years. So while overall quality has improved, the gaps and inequities haven't been reduced. So what we'd like to do is take our learnings of how valuable paying for performance is, and really transition this pool to be focused on driving equity, and specifically on driving efforts at the local level to be more upstream. So anticipate setting basically a core set of sort of standard, we call downstream metrics that are sort of tied to health outcomes downstream. And have the metrics that the metrics and scoring really spends its time focused on to be really new, upstream, innovative, equity focused metrics. Probably fewer set of those that will take a longer period of time and don't evolve as much. But we've been really sort of stuck in a cycle of, as we're trying to promote equity, the only metrics that folks really have felt comfortable adopting are nationally accepted metrics. Those are largely downstream metrics. And so rather than constantly changing those every year, really pick a core set and move our energy to developing new upstream metrics. The other piece of this is really improving decision-making of communities and increasing the voice of communities in the process. So anticipate really changing the model of how this works. Right now, the health plan quality metrics committee sets a set of measures, largely those nationally accepted measures. They have a menu, metrics and scoring can choose from those. What we'd like to do is evolve the health plan quality metrics committee to be an equity focused committee that's not picking metrics per se, but is really picking core equity priorities with strong community and voice in that. And from there, then having metrics and scoring dive into the details and figure out exactly how to measure that and the data set and the specs. But to really move from that's first starting point is picking a menu to the first starting point is establishing priorities driven by the community. Next slide. Next, I'm going to go to the next slide. I think I've covered most of these. Next slide. So the final area, the 4 areas, is around focused equity investments. And there's two things that we're trying to weave together with this. One is how we will implement House Bill 3353 that came out of the last legislative session, which directs CCOs to pay 3% of their global budgets into equity and behavioral health and community investments, and it specifically requires one of those percentage points. So 1/3 of the 3% specifically to go into community, and sets up a new oversight committee to guide that process. Secondly, and more directly, what's in the waiver is we're asking for some new federal dollars on top of that. We're asking for the federal government to recognize savings that we've had within the Medicaid program over the years, as well as savings that we'll have if we can really move towards promoting population health and move to a global budget model that really helps contain total cost of care. Recognize those savings and recognize that we also need to shift dollars and make some new investments in areas to address inequities. And so we're asking for some federal dollars that are above and beyond what we would already be paying CCOs to invest into the community to address inequities. So we'll go to the next slide. And so what was proposed is new community investment collaboratives that would come together to decide where these two investments go, the 1% coming from CCOs, as well as the new additional federal dollars on top of that. This is obviously, I think, sticking points Can you still hear me? I was worried about- Can you hear me now?
With your mic, there you go.
Okay, I just switched to headphones for all of a sudden for some reason. Okay. This has been one of the, I think, stickier issues with CCOs. And just want to provide a little bit of background here. Is the policy board's health equity definition calls out a critical piece of addressing health equity is really shifting decision-making and power to into communities that specifically have been facing inequities. So as we're thinking about dollars that are going into the community and are targeted specifically towards addressing inequities, have felt like those dollars need to be closest to the populations that are actually facing inequities. And we've heard through the regional health equity collaboratives and others that if we're talking about investments that are going to the community and investments that are aimed at driving equity, that those need to be as close to the communities that are facing those inequities as possible. So we've proposed community investment collaboratives. These are be very flexible in terms of how they could come together. There's no predetermined region or predetermined lead organization. What we'd really like to see is community come together and put a proposal together for how the CCO, how the RHEC, how others in the community would come together in a collaborative, designate among themselves a lead organization, designate among themselves who would have the financial responsibility, but really have the community drive that. Once those collaboratives, we're thinking of the House Bill 3353 and the 1% being sort of the infrastructure build of that. And then if we're able to get additional dollars from the federal government, those would also go into the collaboratives. Next slide. Next slide. We'll need two things from the federal government to make this happen. One is we do need the federal government to actually approve these dollars going out to the community and to count them as basically medical expenses in terms of how we build future CCO rates, so that those continue to be baked into the CCO's budget and they don't lose those dollars in future years. The second piece is around any additional federal dollars, and we really don't know whether this administration is going to be open to this or not. The last administration shut down the two federal programs that allow states to request federal dollars through waivers. They're called DSRIP and DSHB. Two other states are ahead of us in the waiver process, New York and California. They've both asked for dollars in their waiver application. We have no idea yet whether this administration will be open to providing states investments like this. So this, I would say, is pretty tentative, and we don't really know, but we're proposing it and feel like the best. Really, we're in a different situation. Folks remember in 2012. We requested and received almost $2 billion in federal dollars through our waiver. That was largely to launch CCOs and to protect against some pretty significant budget cuts that were going to happen. Here, we're really talking about additional dollars above and beyond what we're already going to pay CCOs, and are really going to make the case to the federal government that these dollars are specifically needed not to fill a budget hole or a budget gap. It's really needed to specifically address inequities. Next slide. So where we're hoping to go with this is really to continue to build on work through CCO 1.0 and 2.0 of increasing community voice and decision making, and building out more infrastructure to be able to have community organizations help address some of those social issues that are really needed in order to address historical and contemporary injustices. Next slide. As I mentioned at the top of the hour, we're also requesting that pretty much everything that we've received in our last waiver continue. Those are really core elements of the Oregon Health Plan of CCOs, and so a lot of the stuff that's in the current waiver we feel like is working and needs to be continued, including continuing the prioritized list of health services as the way we design the core health benefits. And continuing the Health Evidence Review Commission as a transparent process for establishing benefits within Medicaid, continuing the coordinated care model, continuing to push towards value-based payment, commitments to quality and access, continuing community advisory councils, and strong tribal engagement and collaboration. So all those things that are in the current waiver, we're asking to continue. Next slide. And next slide. So for folks out there listening, you obviously there's some folks signed up for public comment today. We're trying to seek most of the public comment through a survey tool that's been put online. Really one of the biggest benefits of this is the ability to capture demographic data of folks who are submitting comments, so we can understand, are we getting comments that represent members, advocacy organizations of members? Is it largely industry? Where are our gaps? So I would encourage folks to use this tool. And then from here, we're going to move into public comment. I think I've got one last slide. We'll be accepting public comment through from December 7th through January 7th. There's a separate process from this on its own timeline around tribal engagement and tribal consultation that will be happening in parallel. Again, here's the website for where you can receive all the materials, email for where to submit questions, and the link for the survey tool. So from here, I think Dr. Bingsberg, happy to take questions from the board or move into public comment whenever you're ready.
Thank you, Jeremy. Just take questions, comments from the board, and then we'll move to public comment.
Hey, Jeremy. I just wanted to share with everyone that the waiver team said that you guys would take any clarifying questions from the public during this portion of the presentation. And we did have a chat question. If you could talk to the strategies of reducing churn a little bit more.
Sure. So we've always known that there's some, it's called churn. It's a wonky term, but what it really means is folks who are moving in and out of the Oregon Health Plan due to either to their income going slightly up and down, and so they're moving from the insurance marketplace into the Oregon Health Plan and back and forth. Especially hourly workers or seasonal workers. And then we also see churn in folks who every time they have to go back through the application process, they have a change of address, they get confused by the process, maybe they no longer think that they're eligible for some reason, have other things going on in their life and miss the window, don't submit some of the supporting documents, a whole variety of reasons that they're actually eligible, but they lose coverage. And then we see them come back in 3, 4, 5, 6 months down the road when suddenly they have a health event and end up at the hospital. So the point here really isn't to just insure people, just to insure people. Having people have insurance and be enrolled is how they access the healthcare system. Very few of us have enough money to sort of self-insure and just cover everything out of pocket. And so having that continuity of coverage is critical to then having continuity of your provider relationship, continuity of access to primary care. What we worry about with folks in churn who are churning in and out is they aren't accessing the preventive services that prevent something worse from happening. And suddenly, a behavioral health crisis happens or other event and they end up in the hospital. We want to reduce that. We want people to have that continuity with their primary care provider and community behavioral health providers and others. It's also extremely disruptive. I was thinking the other day about, how often I would change car insurance. That's much less of a hassle than changing health insurance. And I would never imagine doing it on an annual basis, but we have people change health insurance every year or multiple times a year. And every time they do that, they have to go figure out who their primary care provider is and what drugs are covered. And it's hugely disruptive. So the goal of churn is really to reduce that disruption and keep people's coverage more stable and connected to the system. We've learned through the public health emergency over this last year, I think, more about churn than we've ever known before. And that's because we stopped doing eligibility redeterminations, and those will turn on next year, meaning that if people don't fully submit their application, or haven't verified income, we aren't kicking them out right now. We're pausing and we're still continuing to enroll them. And what we've seen is we've had about 300,000 people come into the Oregon Health Plan, and the only folks coming in on a monthly basis at this point largely are folks who've never been on the Oregon Health Plan or haven't been on for more than 2 years. So we think this 2-year mark is a really critical strategy to stopping that churn. If we could move from 1 year to 2 year, we're more likely to keep people who are actually eligible in, stabilized, not bouncing in and out. And if their income's going up and down throughout the course of several years, and they're moving back and forth between the marketplace or OHP, by moving to a 2-year eligibility, we're keeping them in the place that they're most likely to be most of the time in the Oregon Health Plan. So those are our strategies really around churn.
I have a question, Jeremy. I agree that changing your insurance every year is a challenge. Sometimes that we have to do that as a private company because our rates are just crazy. If you get a 20% increase, you just have no choice but to change your coverage. But we try really hard to keep it the same for at least 2 years. What if someone does lose eligibility temporarily and has to reapply? What are the other things that are done to try to keep them connected with their preferred provider or the provider that they had been seeing?
Thanks, Jessica. We do a number of things to try to ease the process when people apply. And we're required by law, as an example, to look at other data or information that we or DHS have that might help determine eligibility, whether that's income or other information. So if they apply, we're supposed to try to gather the information that we have internally in doing that application process. When folks leave and come back, generally we re-enroll them back in the CCO that they were at previously. And so in the Medicaid space, most places folks, their primary care provider is not going to change so much because we have most of the states covered by one CCO, and the networks aren't changing as, it's not much of a network difference as you see in the commercial market where you're picking plans, but they're still losing that disruption to the primary care provider in the meantime, if they bounce out for 3 or 4 or 5 months. So that's still an issue that we're trying to reduce.
Okay, thank you. Because I thought I heard you say that, they end up losing their provider and have to start new relationships, which is problematic.
Yeah, and I think that definitely happens. I think we reduce the amount of time that we can. We try to enroll folks back into CCO. I think a lot of CCOs diligently do reach out and try to get folks back connected. But every time they lose eligibility, there's just a whole bunch of new barriers or things that can get in the way to getting back connected to your primary care provider.
Do we have data on how long people typically stay enrolled in general? Is it forever? Is it 3 years, 4 years, 10 years? Do we know?
I don't have that off the top of my head. It varies largely depending on why folks are in to begin with. So there are folks who are eligible based off of disability. Those folks largely aren't their eligibility largely isn't changing. Kids. We cover kids up to 300% of federal poverty level. About half of the kids on the Oregon Health Plan are enrolled are born onto the Oregon Health Plan, and they'll stay on the Oregon Health. A lot of them will stay on the Oregon Health Plan most of their life, or most of their youth, I should say. For adults, though, I think it's adults who are based on income and not disability. It's a different story, and really depends on what if they're low income workers, if their income's going up or down. So I don't think there's one figure to look at. I think it depends on the population.
Brenda, I see you have a question.
Thank you. 2 questions for you, Jeremy. I know you've done a great job educating us about how the 1115 waiver isn't the only opportunity that we have to make transformational change in the Oregon Health Plan and the OHA's policy. I wonder if you can speak a little bit more about the other mechanisms that we have. And then my second question, and I appreciated this in your slides, about how we've integrated public comment already during the planning process and the things that have shifted as a result of what we've heard. Can you give a little bit more context about how we intend to integrate public comment from this last leg of this long journey before we submit in January? Thank you.
Thanks, Brenda. Yeah, there are a variety of tools we can use to change what happens within the Medicaid program. I mean, sort of starting at the macro level, the broad strokes are laid out in federal law that you can't waive out of. They're in federal statute, and then the federal government has a set of its own regulations, and we provide input on those all the time and try to seek guidance from the federal government on those. Example is right now. We're expecting the federal government to put out some guidance at some point this winter on what CCOs can be doing or not doing in terms of helping people re-enroll. And so they'll be putting out some sub-regulatory guidance that we can then use with CCOs that we don't need. It's outside the waiver, but will help us try to figure out how to manage the program. We have our own set of administrative rules. We can propose statutory changes to the legislature. There's the state plan amendments. There's our CCO contracts that help define the program. There's things like the prioritized list that's always evolving. So we recognize this is super confusing, right, for an average person, and don't expect that that folks know what the tool is. We really feel like that's our job to figure out where the tool is. What we really need to be doing through this process is collecting the problems that we need to fix. And I think where we're trying to move to in the future is to getting as an agency into a more consistent, ongoing dialogue with the community about what the problems are, and then taking that and reporting back to the community where we put it. Was that a waiver thing? Was that a rule thing? Right now, we've unfortunately been having a lot of sort of isolated conversations, but that's our goal, is to get more into an ongoing dialogue. But those are a few examples of other places where, as we've been getting input, the appropriate place to make the change actually might be a different tool or lever. In terms of the feedback, I mean, we'll be posting all the feedback all the comments that we've got throughout the month online. We'll be doing a edited version, and then we'll be describing for every comment that we receive what change we made or what change we didn't make and why that was.
From John, and then Jessica, and then back to Tara.
Yeah, Jeremy, thanks for that presentation, and I just want to enthusiastically support the direction OHA is going in terms of the waiver. I think this is really solid health policy work that is a stretch, and kudos to OHA. A couple of minor issues. In the transitions, you included the dual eligible Medicare transition in your slides, but didn't discuss it. I do think that's, as I've listened to a discussion, I've been surprised at the trickiness of that transition for many folks, and happy it's included. And you may want to make more mention of some of the things that are involved in the future. Just a comment about downstream metrics. I mean, I think Oregon deserves a ton of credit for the work it's accomplished around metrics, but there are some very significant gaps that aren't included. I mean, Oregon does not really measure hospital metrics, and it doesn't measure specialty metrics. It is doing a good job of dental or oral health and now behavioral health, but there are some gaps in terms of those downstream metrics that are really important. And I don't think it needs to be part of the waiver discussion, but I just want to get that on record. That's an area we should consider going forward, to be more transparent about in terms of improving our performance. So good work, and thanks for the presentation.
Great. Thanks, John.
Jessica?
Yeah, so I was looking through some of the more detailed material, and I wanted to talk a little bit about the Community Investment Council piece. And when I saw that, it was a little bit new to me. Maybe we had talked about it before, but I don't remember seeing it. And it sounds like there's going to be like a grant process potentially. And when I was thinking through this, I'm concerned that we're adding even more complexity to the way that we are tackling this issue of equity and investments. And, we're siphoning off dollars from the CCOs, and then we have this group that's supposed to come together. I didn't see it in the original bill when we looked at that. And I'm worried that this is just going to be kind of expensive, slow down the process, and we're not really going to get the results that we'd like.
Thanks, Jessica. Yeah, the evolution of this, we originally proposed call them health equity zones, and that really spun folks up because it sounded like we were going to go preset some regions, and that really wasn't the intent. The intent was really to have the community come together, much like they do right now. We've been really pushing to try to have one community health needs assessment and community health improvement plan that spans across the hospital and local public health, and the CCO and other community partners, and try to create more sort of bridges across systems and out into the community. So we had evolved that into a collaborative that would be flexible, that the CCO and other partners can come together and basically propose how they'll work together. You're right. You are right that what we're talking about here largely is not entirely, but largely is sort of new federal dollars that are above and beyond what we're paying the CCO, and we're imagining that is sort of a grant process that the community comes together and says what's the priority or what's the need. And the reason that we really propose this outside of the CCO is because it's largely dollars that would be above and beyond what we're already paying the CCO, and was really directly responsive to some community input that there be a stronger community voice. So welcome other opinions. Just wanted to kind of give you the background on why we proposed it that way.
Yeah, I think we already have, we have a lot of community input from what I could tell. And there are dollars that come from the CCO budget that go into that pool. So it's not just federal dollars, right? Or is it all brand new?
No, there are, right. So where it is right now, CCOs, they do make investments into the community, but it varies pretty dramatically. There's not a hard and fast rule on how much they have to invest. We've been pushing to have those dollars be more tied to their community health improvement plans. But they all do it a bit differently and in a different way. Some through their community advisory councils, some through grant processes, different criteria. So it is happening, not as much, frankly, as I think we had expected when we launched CCOs, and it varies quite a bit between CCO.
I guess what I was meaning is they will be paying into that pool of money that potentially would be combined with federal dollars. So it's not just new dollars that would be granted out. We're taking some from the CCO budget and combining it. Is that correct?
Yeah, that's correct. We have to get federal approval for that, but that's part of House Bill 3353 that passed this session that specifically directs the CCOs to pay 1% of their global budget into the community.
Okay, because that's that's pretty different, I think, than what I read in that 3335 bill and sort of what was proposed in there. And so I don't know how much room for interpretation there is for that. But I think again, my concern is that we're going to be spinning up this new process. We already have a really complex relationship with CCOs, a complex sort of funding mechanisms for CCOs, and we're asking them to do a lot. And then we have a lot of other layers, having to do with behavioral health and a lot of other things that we were asking people to do, including making these investments in these communities based on health equity. I worry that we're going to shoot ourselves in the foot here and make it more complicated than it needs to be.
Thank you.
Ebony, and then Oscar, and then Kirsten.
Thank you, Jeremy. And I think what I appreciate is just the intentionality that's being put into this in terms of thinking about how we want to enhance, improve, and transform And I appreciate, us thinking about kind of the through line specific to elements that are broader than just literal primary care or behavioral health care. So I think about, the housing elements and things like that. Many have already spoken to the things that I was going to raise. And so, because again, I'm also just thinking about, and I'm super excited to see this impact on the population of those who will be exiting custody and reentering the community. And long story short, I just think that there's a lot of work to be done, and we're only going to be successful if we recognizing that it's more than just the responsibility of the CCOs. It's more than just the responsibility of OHA. But I'm excited and feeling hopeful because we're doing that forward thinking, and I hear everyone connecting the thoughts and saying, okay, this is the first step, but for this to be successful, for this to be sustained, it's a broader strategy that has to been brought forward. And just again want to just reiterate the importance of how do we set something up that is not aspirational but feasible, understanding that this is going to be an iterative process. So thanks.
Stephanie.
Oscar, do you have a comment?
Yeah, very similar to what I've just been hearing too. Mine was going to be focused on the community investment collaboratives. I'm excited about this idea. I think it's always great to have community be more, have a bigger decision around investments. My only, sort of things that I want us to make sure we're thinking about is how are we connecting this to existing structures? Like, how are the regional health equity committees or how are the community advisory councils going to be connected or involved? I just worry that by, standing this up fairly quickly, it could leave some organizations at a disadvantage who may not have the capacity to be able to step into these roles really quickly. Again, sort of reinforcing the organizations that are either more mainstream or more well established, being able to benefit by being able to easily stand up these collaboratives or be the lead on these collaboratives. So just want to make sure that we're really intentional and thoughtful about creating space for culturally specific community-based organizations and more emerging organizations as well.
Thanks, Oscar. Just one clarification. So while we're having these conversations with the federal government over the next year to find out whether or not they're willing to give us these additional dollars or not, the intent is that we are beginning to work with community around those collaboratives so that they are starting to form and do that infrastructure and planning and have time to do that before the dollars actually would be flowing to them. And so that's the intent, is to be sort of in parallel out there having those conversations to support the community.
Kristen, you had your hand raised earlier.
I did. Most of my comments were mostly covered. I will add to echoing support. I appreciate a lot of the concepts in our waiver and forward thinking. And one thing that I'm looking forward to, because of the inclusion of some concepts like the CICs in the waiver, is kind of not only that increased kind of accountability and community voice in the distribution of those dollars, but also because it will be part of the waiver process, how are we more actively monitoring kind of impact? And I appreciate the discussion around metrics and necessary development that needs to be done there. I feel like we, meaning mainly the nonprofit healthcare industry, has thrown a lot of good money at kind of community benefits, but mostly in a black box. And so I'm looking forward. I think there's some opportunity in this process to kind of think about how we are investing and seeing impacts of those investments on a variety of metrics. I'm really looking forward to that and supportive of this effort. Thank you.
Thanks, Kirsten. Ebony, I see your hand is up. Is it from the prior comment, or do you have another comment you'd like to share?
Oh, no, sorry.
Okay. All right. Tara, we had some clarifying questions from the public we wanted to raise.
Yes. Jeremy, I did have another question for you, but also a follow-up question to the question asked previously about churn. Follow-up question is, when you talked about reducing churn for those whose income varies widely on a regular basis, they're asking, will they still need to report all those changes within 10 days?
I need to go back and check with the team. I believe the changes in eligibility unrelated to income if they move out of state, something like that. But I'm not sure about the income. So let me have to look back on the team.
Okay, I'll capture their email address so we can get that answer to them.
Our intent is to smooth out those ups and downs. So certainly if people's income is changing every 10 days, we don't want them churning in and out every 10 days, but I need to probably go back and talk to the team a bit more.
Okay, we had another question regarding the SHARE initiative, which for those who don't know stands for Supporting Health for All Through Reinvestment. And they're asking, how does OHA envision SHARE fitting in with the new community investment part of the waiver?
So SHARE is a program that is coming out of a bill that passed in 2017 that was really aimed at, it was Representative Greenlake's bill I'd worked on for several years, and was really aimed at addressing high reserves in the early years of CCOs post ACA. So folks may remember the first 2-3 years after the ACA passed and we did the Medicaid expansion, CCOs reserves grew pretty substantially, and there were a number of legislators that were frustrated that they weren't seeing those dollars go back into the community as we sort of initially envisioned with the CCO global budget. So and so what SHARE is designed to do is to basically say if a CCO has excess reserves or income above the minimum financial standards that we require them to hold on to, that a portion of those be invested back into the community. So it wasn't really intended to be the core investment. The idea was if a CCO is not making investments and accruing large income or reserves, that it's sort of a backstop. Frankly, if we are able to get the global budget changes that we're looking for, we would imagine SHARE almost goes away. It's statutory, so it would need to be a conversation with the legislature, but would probably be really a much more slimmed down backstop because we would just really change pretty dramatically how we're paying the CCOs. It would maybe still need to be a mechanism to make sure that that dollars are actually going out to members, like we've got a medical loss ratio, but would imagine redesigning it in lieu of whatever we get from the federal government. We don't know what's going to happen right now with the federal government, and that bill has been several years in the making. So we've done rulemaking, and we've turned that program on. We wouldn't expect that any of the global budget changes we would get in this waiver would be implemented until the next 5-year waiver or CCO contract, which is until 2025. So would imagine SHARE continues, but then we would reconsider how it fits into global budgets as we're launching the new global budget methodology in 2025.
Great, thanks. I've received one other question. I believe this is the last one. The question is there anything in the waiver renewal is there anything in the waiver renewal to improve transparency at CCOs, such as making them subject to state open government laws?
There's nothing directly around state open government laws. In that same bill that implemented SHARE, the legislature directed CCOs to hold certain public meetings, and that was really a compromise of several years of legislative debate. And we have not proposed any changes to that specifically. We do think that as part of moving to a new rate methodology, accountability is even more important than, it's always important, but we think there's a huge element of that proposal that needs to be some really robust transparency and accountability around what's happening with quality, what's happening with access to care. If CCOs are going to have a longer, more flexible budget, making sure that they're still providing the necessary care, covering services, that access isn't going down. what we want to see and what we would imagine measuring is, are we seeing things like investments in high value primary care and community behavioral health go up? Are we seeing avoidable hospital visits go down? We also want to be tracking for sort of unintended consequences. Are we seeing reserves grow and access go down? Well, that would be a problem. So we would expect there would be a strong accountability mechanism of monitoring what's happening with CCO spending and making sure that we're not seeing any unintended consequences, and that would absolutely be a core part of it.
Jeremy, thank you for a great presentation. I also want to thank the board for a really detailed, thoughtful discussion, as well as the public for providing their comments. Are there any other questions or comments before we move on to public comment? Thanks again, Jeremy. Well done. Really well done. So we're going to break up public comment into two different sections. First, we'll have public comment on the 1115 waiver process, and then we'll have more general public comment. We have a fair amount of comments today, and we're glad we have the time to pay attention to those comments, listen to those comments. It's really, the public comment is one of the most powerful ways that the Oregon Health Policy Board and OHA can get feedback. We're committed to profound listening and learning from your comment. As part of that listening and learning process, we won't respond directly to your comment today, but Vice Chair Arana and I will review all the public comments with the OHA staff after in our follow-up meeting and discuss any follow-up that is needed based on your comment. So we want to thank you very much for your comment, and we will listen carefully, and we will review the public comment in a subsequent working meeting. The public comment, you each have 2 minutes for your public comment, so please keep in with the 2 minutes to share your ideas and your comment. We have this slide that will count 2 minutes down, and please conclude at the end of the 2 minutes. We ask that you state your name and your affiliation for the record. And let me pull up the list. And we will start, we have 5 waiver comments, 1150 waiver comments, and we'll start with Josh Bollock.
Hello, I'm Josh Ballock and work for All Care Health. All Care CCO serves members throughout Southern Oregon. All Care is a certified benefit corporation, and this year we were named one of the top 200 certified benefit corporations in the world. The Oregon 1115 waiver is a huge piece of policy, and All Care will be giving extensive written comments about the waiver as a whole. But we wanted to highlight to this oversight committee significant concerns around the current draft, specifically around the third-party equity silo concept and how it conflicts with the bipartisan bill of House Bill 3353. I can tell you that the current draft of the 1115 waiver does not align with the bill as written. To be clear, we are extremely supportive of incorporating more diverse voices and having a community accountability to ensure that the health needs of all people are being met. Our concern is that these third-party equity silos bifurcate efforts and that they are unsustainable in a grants-based system. As someone who was part of the group who helped work on HB 3353, we were actively trying to move past this grants-based system to a sustainable funding model that could push large systems changes. These undefined groups that would be separate from current community efforts and locally based community advisory councils and all the amazing efforts that are currently being pushed. It is our experience that the #1 issue with sustainable equity investments for the community has been, in fact, the fact that CCOs don't have a true global budget, not the lack of one of our councils, our community boards, or locally based community organizations. Also, the 1115 waiver draft fails to call out many of the accountability measures in HB 3353 that ensures community voices are included in spending strategies and efforts to hold CCOs and the OHA accountable. There will be a letter fully outlining these concerns sent later this week. We would ask that you read it and consider the implications for the current draft waiver proposal and not following 3353 as written. Thank you for your time.
Thank you very much. We'll turn to Paul Turdal.
Thank you. Can you hear me okay?
Yes.
Great. So my name is Paul Turdahl. I'm a resident of Northwest Portland, and I'm testifying as a member of the public and as a father of 2 Medicaid-eligible children with disabilities on the 1115 waiver. I'm really expanding and following up on testimony I delivered last May to this board. That's in the record regarding 2 specific things: the EPSDT waiver provision and use of quality-adjusted life year metrics in the prioritized list. Since my testimony 7 months ago, I have met with a number of physicians and families on OHP who have struggled to access medically necessary care for patients and children just to learn about the impact. Some very basic findings: many of the condition treatment pairs that are below the line for coverage are really debilitating but treatable, and denying coverage can lead to significant harm. A couple of key examples: selective mutism is 2 rungs below the line. Children who can't access care are unable to fully participate in school and community settings. This was marked below the line because the HERC Commission found that while the treatment was highly effective, the condition just didn't matter much to patients, and so it was defunded. I think any patient you spoke to or any parents would disagree with that. The other is that physicians frequently resort to code games to just work around the prioritized list, finding a different thing that would be covered, which ends up distorting the record and just creating additional bureaucratic obstacles that really increase costs rather than reducing costs. Just to summarize, I would really urge you to remove the existing provision on EPSDT to cover all medically necessary care for children as the EPSDT law requires, and again, to stop using polys. In my written testimony, I have provided additional comments as well as a couple of issue briefs from Disability Rights Oregon on both of these topics. Thank you.
Thank you very much. We'll turn to Michael Paruk.
He's my spouse. He won't be able to present, unfortunately.
Would you like to speak for him?
I mean, sure. I'm also speaking on my own amount.
Okay.
So.
Oh, you're Emily. You're up next on the list. So please go ahead. Right. So restart the clock. Go ahead. Thank you.
Okay. Sorry about that. Yeah. So my name is Emily Fern-Dayton. I am. Thank you, board chair and members of the OHPB committee, for hearing my testimony. It really means a lot. And I'm writing to you today, and I also provided written testimony, so I'm not going to provide the whole amount, for a change to be placed within the Medicaid 115 waiver to allow biological and adoptive parents to be paid caregivers to their minor children who have disabilities and chronic complex medical conditions. Apologies, I am caregiving right now and tube feeding, so just a little look into my life. I really appreciate that OHA has a focus on equity and intentionality of learning from community members with lived experiences. So to me, this is completely interrelated with the parent is paid caregiver ask. It's really hard to describe what it's like being a 24/7 caregiver. We really, first and foremost, don't get to parent, honestly. So there's, constant hours of medical appointments, case management. There's just a lot to manage. And I just want to state, as a white, cisgender, able-bodied, neurodiverse, bisexual, queerish woman who is married in a hetero relationship, I've found the system honestly nearly impossible to keep up with. The constant need for advocacy, constant changes, case management, medical, educational, and therapeutic tasks on top of being up with my daughter who has medical emergencies and seizures overnight. It really makes me think, I can't even imagine how much higher this burden is on parents who are from historically underrepresented communities, such as those who are BIPOC and have intersectional identities. In our situation in particular, my child's tube fed about 8 to 10 hours a day. And the specificality behind that is her blenderized feed is so precisely measured down to the ½ ounce that if you mess up as far as the keto ratio, then she'll have status seizures, constipation related to low motility issues of reflux, etc. So why am I stating all this? I could go on and on about what her amazing abilities are and the ongoing medical conditions she has. but I also don't want to reiterate kind of ableist thinking, because for far too long, children and adults with disabilities and chronic complex medical conditions really just haven't been included in discussions due to inequality and structural ableism. And there's a lot of experiences I could state with that, where my child has been called the R word by medical professionals. Anyways, I don't want to get emotional. So the reference that I want to state is that the state of California actually pays parents of children who have disabilities and are medically fragile. And we do ourselves have members of our support community who've been forced to relocate to California in order to be successfully support their children's medical needs and alleviate this ongoing financial strain that many of us experience.
Thank you very much for your comment. We'll turn to Gabriel Triplett.
Hi, I just want to start off by saying that I wasn't aware of the 2-minute timeline, so I'm just over 5 minutes. I hope you'll bear with me. We did make.
I don't think we can. I'm sorry, we can't make room for 5 minutes.
My name is Gabriel Triplett. I'm a husband, a father of 3, a community advocate, and an organizer. I'm here to appeal to you today about an issue that affects my family directly and thousands of families in Oregon. Currently, the state of Oregon does not allow biological or adoptive parents to qualify as paid support workers or direct service providers of their underage disabled children. Family and hundreds of Oregon families are demanding this be changed. When my son Oscar was born just over 9 years ago, my wife and I began a new chapter in our life, one of raising a medically complex child. This new chapter required we move from a two-income family to a one-income family. Honestly, with the amount of therapy visits, hospital admissions, and level of constant care that my son requires, holding down just one job between the two of us has proven extremely difficult, and at times it has been impossible. Regularly, my wife and I, while barely holding our head above water, will stop and reflect, how could we do this if there was just one of us? How could we do this if we didn't speak English? How could we do this if we didn't have backgrounds in system navigation and organizing? And the answer is we probably couldn't. The truth of the matter is, if you talk to any social worker involved in foster care in Oregon, they could tell you way more stories than you'd like to hear about families of disabled children ripped apart simply because it was all too much. But it doesn't have to be. When the pandemic hit, families like mine organized. Over 3,000 families signed on to a petition to plead that the state amend their 1915K waiver to allow parents to qualify as PSWs and DSPs. And in January, we're giving a temporary allowance for the duration of the PHE. This allowance has literally been a lifesaver, but it's about to end. I want to be clear about something. For our families, the pandemic didn't bring any new problems. It simply brought our problems into a shared timeline and gave typical families a glimpse into our normal. Community spread of virus that threatens our children's lives and prevents us from accessing outside help is not new for us. Assessed hours of needed support going unused due to staffing shortages is not new for us. Losing our jobs, our housing, our relationships because we need to stay home and to prioritize the safety and the health of our children has been a new experience for so many during this pandemic, but it is not a new experience for families with children with disabilities.
I want to thank you for sharing your
Yes,
comments.
when returns to their normal,
I would like to invite you to share the rest of your comments to the 115 waiver renewal team at 115 waiver.renewal. And that's available in the chat. I want to thank everybody for sharing their personal stories as well as their public comment. We will now transition to comments unrelated to the 1115 waiver, and we'll go to Jackie Luong.
Hi, everybody. Can you hear me okay?
Yes, thank you.
Okay, great. Hi, everyone. I just want to say a quick hello. My name is Jackie Leung. I'm the Executive Director of the Micronesian Islander Community. We are a 501c3 based in Oregon. We provide a lot of services to the Micronesian community, with the majority of our community from the Kofa Nations. If folks aren't familiar with the terminology Kofa, Kofa stands for Citizens from the Compactor Free Association. So that includes individuals from the Federated States of Micronesia, the Republic of Palau, and the Republic of Marshall Islands. From the Federated States of Micronesia, that includes 4 particular states, Chuuk, Koshrai, Pohnpei, and Yap. I just wanted to say a quick hello and introduce myself. So thank you for the work that you are doing and for having these very difficult conversations.
Thank you very much. Return to Thomas Boos.
Hello, my name is Tom Bussey. I'm a resident of Portland. I hold a degree in molecular and cellular biology from UC Berkeley, and I've also published in the British Medical Journal. My written comments detail how since 2014, the OHA is purposefully inflating its hepatitis C case count. I also detail how pharma giant Gilead Sciences is defrauding the Oregon Health Plan by tens of millions of dollars through a program called Focus. But I no longer want to talk about that anymore. I'd rather talk about my niece. She was murdered last month by the US Navy with a mandatory Pfizer injection. She was 19. To the military and to mandators, it's collateral murder. Having a degree in science, I can read studies. Table S4 of the published Pfizer indicator trial shows a relative risk increase of 42.8% of all-cause mortality and a 4-fold increase of cardiac arrest. This is a shot that increases your chance of dying. It has nothing to do with health. Moreover, information from Pfizer whistleblowers indicates the company fabricated efficacy data. It says on the FDA-approved package insert that these so-called vaccines do nothing to prevent transmission. Patrick Allen lied earlier about that in this meeting. I ask you, what is the point of vaccine verification if it does not prevent transmission? Remember Edward Snowden? Data collected by this system will be handed over to the military and the NSA for mass surveillance. Is that what you want for yourself? Has anybody looked into the military intelligence background of the state epidemiologist? I can assure you, public health has nothing to do with OHA corona measures. Just ask my niece.
Thank you very much for your comment. We will turn to Brittany Aldrich. Brittany Aldrich. Is Brittany Aldrich available? We'll come, if not, we will come back and ask for Brittany again. We'll turn to Dia Bolt.
Good morning. Can you guys hear me?
Yes, go ahead.
I'm Dia Bolt, a mother of 3 from Oregon City. I'm speaking to you today as a mom of school-age children that have been greatly affected by the ongoing mask mandate and lockdowns in our state. My first grader's academics and mental health have been negatively impacted due to the mask mandates in schools. He has difficulty with reading and phonograms because he cannot see his teacher's face or hear the correct pronunciation of phonograms. Even more concerning, my child has been dealing with social anxiety, which is something we never imagined we would be dealing with our otherwise happy social child. This is due to the fact that he can't see his classmates' faces and their expressions while at school. Study after study has proven that masks do not work to prevent the transmission of COVID-19, and that mask use in young children is not only detrimental to their academics, but more importantly to their social, emotional, and mental wellness. And yet, the state of Oregon has continued to mandate them and is now trying to pass an indefinite mask mandate. Director Allen, I'm speaking directly to you. What scientific data and studies are you using to back up the mask mandate in indoor spaces, specifically in schools? What psychological reviews are being done to determine a benefit to risk analysis of long-term mask use in school-age children? My local county commissioners cannot seem to get a response from you, Director Allen, despite repeated inquiries on the answers to these questions. So I'm asking, no, actually, I'm demanding a response. What data, what studies, and what psychological reviews do you have to back up these mandates? And if you don't, which I'm pretty confident that you do not, then it's time for you and your board to be honest and end the mask mandate in Oregon. If not anywhere else, please do it in the schools. If you're going to hold our children's well-being hostage, the onus is on you, Director Allen, to prove the necessity and efficacy of masking in schools. I, along with every mother and father in Oregon, deserve and expect an answer from you, Director Allen, and you have my contact info.
Thank you very much for your comment. We'll turn to Dean Hibbert, please.
I'm so freaking proud of you. I know how nervous you were. I could hear it in your voice, but holy shit, girl. I'm so proud of you right now.
Hello.
We'll turn to, let's start the clock again. We'll turn to Dean Hibbert. You go ahead, Dean.
Hi, my name is Dean Ebert. Thank you for having me. I just wanted to speak on the masks as well. I realize today's meeting is not about that, but that is an upcoming a deal that's going to be impact a lot of people. I have quite a few concerns, but I wanted to touch on a few things that apply to here to Portland. I live in Fairview, and I know that our 911 centers are already or the 911 center in Portland is pretty backed up with phone calls. You can wait on hold for anywhere from 1 to 4 minutes if you have an emergency. And one of the things that they're overwhelmed with right now is they're getting hundreds of calls from business owners regarding people being in their stores without a mask on. And these are not emergencies. Even when they call the non-emergency number, this backs up the 911 system. And when you've got somebody on hold for 4 minutes who let's say their partner's having an x-ray or they're not breathing and they need medical advice immediately and they need an ambulance on the way, these kinds of phone calls are affecting the health of the public. And when they're not emergencies, it's not an emergency for somebody to walk into a store without a mask on. And I think we really need to keep things like that in mind, as well as the social, emotional, psychological effects that it has on kids growing up, their speech. How do kids learn to talk to each other when they can't see each other's faces for 7 hours a day at school? I think there's a lot of things that people aren't thinking about that really need to be thought of when you develop these rules advisory committees for a permanent mask mandate. I mean, and not to mention the unconstitutionality of it, the whole thing. So anyways, I just want to throw that in there. Thank you.
Thank you very much for your comment. We'll turn to Michelle.
Sorry, but that's a very ableist perspective. My daughter is 3 times more likely to die.
We'll turn to Michelle McConnell next, public comment.
Hi.
Yes, we can hear you. Well, you're muted for now. There we go.
Is that better?
Yeah, that's better. Go
Okay.
ahead, Michelle.
Yeah, so I realize that this is off topic, but I did want to address one of the things mentioned in your meeting today. You guys had stated that there was an increase in people who had applied for the Oregon Health Plan who had never been on it before. And my question to you would be, how many of those people are from people that have lost their jobs due to the vaccine mandate? And I would think you would be interested in that, considering that you are in charge of some of the healthcare policy for our state. I am one of those people that needs to apply for OHP because of my job loss due to the mandate. I work in healthcare. I'm a nurse. I went to school in Oregon. I can't find a job in Oregon anymore because of the mandate. And in addition to that, there is quite a bit of discrimination that's going on in our state in the healthcare facilities, violating the Civil Rights Act for non-accommodation of people's religious and medical exemptions. I would hope that your board meeting would seriously consider my feedback with all the talk of health equity, given that our state is enabling health policy that openly encourages and promotes health discrimination. For example, the OHA's pursuit of a vaccine passport, as you call it, the Smart Health Pass. How does promoting discrimination with the introduction of a vaccine passport support your goals of eliminating health inequities? How does this honor protected healthcare information if there is no alternative for people to enter a business that uses a vaccine passport? Proponents say that participation is voluntary, but how is this voluntary if a person can't participate in their community unless they agree to disclose private health information? This is the definition of coercion. Thank you.
Thank you very much for your comment. Next, we have David Morrison. Is David Morrison available?
Yes, can you hear me? Yeah, hi.
Yes, go ahead.
Yeah, I wanted to talk about the recent Senate hearing, November 15th. It was supposed to address criticism against or criticism of the OHA handling of Senate Bill 283. That was a science review to determine the safety of irradiating children in schools. So the meeting had Andre Orso from OHA, who was supposed to address criticism. He did not address any criticism at all. And basically, the most important thing he said was that OHA was preoccupied with more urgent public health issues. Later in the meeting, Senator Dembro said not enough money for a serious review of scientific literature was available. So you're preoccupied with other public health issues. You couldn't do a serious scientific review, yet you published a report basically giving a green light to continuing to irradiate children in schools. So later, after the huge public outcry, David Bangsberg revised the statement saying available data does not prove causation, neither do they exclude the possibility of a causal effect. So how's OHA going to handle this? Are you going to just let this review continue the way it is, or are you going to re-edit the review, include David Bangsberg's comment, or basically what should happen is the review should be retracted and done again? Now, animal studies were not used, and the reason is because journalist Dan Forbes obtained emails between OHA staff referring to the recent National Toxicology Program study that confirmed cancer and DNA damage, and they decided then not to use any animal studies. So.
Thank you for your comment. We'll turn to Kevin Fitz.
Hi, good morning. Can you hear me okay?
Very well.
Yeah, hi, Kevin Fitz. I'm the executive director of a 501c3 called the Oregon Mental Health Consumer Association. And I'm here again to put a point in definitive and defining language. The motto of my organization is called "Nothing About Us Without Us." And it's a slogan to communicate the idea that no policy should be decided by any representative without the full and direct participation of the members of that group affected by that policy. I started working in consumer engagement activities in Oregon in about 30 years ago. And up until for the first 25 years of this work, there was distinct and defining language that the Oregon Health Authority and the state of Oregon used to identify a Medicaid consumer, i.e. service user, customer, or client. I am very dismayed by the new boutique language of persons with lived experience does not define that person is, has been, or may be a customer of the Oregon Health Plan, particularly under behavioral health services. I am very glad that the Oregon Health Authority is engaging folks with mental illness to help advise their projects. But let's please distinguish between a peer services person with the lived experience of mental illness is actually an employee of the state of Oregon by contract. That seat should not be usurped or taken by a peer when it's designated for a consumer, a client, or a customer. I am working on legislation for 2023 called the Consumer Engagement Act in Oregon. And one of the things I'm going to define is then what OHA talks about stakeholder representation, that they do a distinct head count of Oregon Health Plan customers engaged, because I think there's a lot of bait and switch going on with this new, very vague and indistinct language saying we have 14 members and 12 of them are people with lived experience. It does not define what is or what is not a customer. And I want to continue to keep making that point. And also, I want to support Ebony Smith-Clark's points earlier about that. Thank you very much.
Thank you very much for your comment. We'll turn to Eva Bortnick, please. Is Eva Bortnick here? I will come back I recognize I missed a few people on the waiver comments. We have 2 more waiver comments.
Hi. Oh, I can go now. I'm
Eva,
sorry.
Go ahead, Eva.
I'm
Yes.
sorry. I was muted.
That's all right.
My name is Eva, and I have been disabled by electromagnetic radiation for many years, and this for over 2 decades. Recently, the United States Courts of Appeals, DC Circuit, said that the Federal Communications Commission failed to uphold the Administrative Procedures Act when it decided not to review its exposure guidelines for radiation that has occurred since 1996. Petitioners submitted 11,000 pages of evidence showing harm from this radiation, and everyone is affected. In particular, the court said that the FCC must, and this is a quote, address the impacts of RF radio frequency radiation on children, the health implications of long-term exposure to radio frequency radiation, the ubiquity of wireless devices, and other technological developments that have occurred since the FCC last updated its guidelines, and also addressing implications of radio frequency radiation on the environment, close quote. We really need to stop saying that because radiation is invisible, it's harmful. And I would like to ask this board to help protect Oregonians by educating the public on how to reduce radiation exposure, hardwire, and require that public schools be hardwired. Also, the OHP does not have anybody that can diagnose and treat environmental illness. And I would like to request that they do get somebody in each region that can help the people with my disability. I would be happy to talk with you further and provide more information if you would like. Thank you very much.
Thank you very much for your comment. We will go back to 2 individuals that we missed on the waiver comments. We'll start with Lisa Ledson. Lisa Ledson here. All right. One other person we missed in the waiver comments was Elizabeth Wright. Is Elizabeth Wright here?
Yes, thank you so much. Hi, my name is Elizabeth Wright, and I'm the program director of North Star Clubhouse in Portland, Oregon. North Star Clubhouse is a non-clinical SAMHSA recognized program designed to provide people living with a mental health diagnosis a place to find structure, community, and peer support. North Star Clubhouse is requesting that language be either added to the current Oregon 1115 Medicaid waiver agreement that would make it possible for Clubhouse programs in Oregon to bill directly to OHA for the specific and unique services that Clubhouses provide in the state, or clarify which paragraphs in the current waiver contain language specifically to allow this. Several states have already added language in the Medicaid waiver agreement that specifically allow Clubhouse programs in those states to use billing codes created by the Centers for Medicare and Medicaid for that purpose. Clubhouse programs are very unique and provide a service that is sorely needed in our current mental health delivery system, specifically psychiatric rehabilitation and an off-ramp to inpatient hospitalizations. Clubhouses are low cost and are open 6 to 7 days a week, 8 hours a day without appointment. We've been able to navigate the COVID pandemic by keeping our doors open, and Clubhouses provide a daily structure that are targeted in helping people prepare for employment, socialization, and reintegrating into the community. And having the Medicaid billing would make a huge difference in our services. Thank you so much.
Thank you very much for your comment. Is Lisa Ledson available? Okay.
I know she is. She's my friend. I just texted her. Sorry. She
Okay.
should be coming.
All right, well, we have one more person to turn to. I'll come back. If she joins us, she's welcome to provide comment. And the other person we called on but wasn't available is Brittany Aldrich. I want to check to see if Brittany Aldrich is here. Lisa Ledson.
I'm here. Can you hear me?
Yes, please.
I'm
go ahead.
sorry. Thank you. I stepped away for just a moment. This has been very interesting to watch. Thank you for letting me even participate. I have never done this before, so this will be my first time. I am a registered nurse in an emergency department here in Oregon. I have been for the last 14 years, and I'm also a parent of a 9-year-old disabled little girl. I first of all, everything that everyone on this call, this Zoom meeting does a day in a life of themselves. Thank you. I know how hard it is to be in the trenches of all of this. There's tough decisions that get made every day. And at one point there was 118 people on this call, and now there's 92. And I think you all individually and collectively do amazing work. So I just really want to acknowledge that. I obviously, as a parent of a disabled person, am here to advocate for any streamlining of Medicaid benefits, whether it's insurance, being equitable in decisions that are made, be advocated for, and every decision that's made by this committee needs to have the forefront of the most that are underserved. And I am telling you that is the majority of the parents, or that's the majority of the patients I care for in the emergency department regularly, but it's also, you know, families like mine. So please don't forget us. We're small, but we're really important, and we are your litmus test. If we are not doing well, then the majority's not doing well. So don't forget us, okay? Thank you very much, and happy rainy day. Hopefully the sun comes out.
Thank you very much for your public comment. That concludes our public comment section. I'd like to thank everyone for sharing their comment.
Excuse me, Dr. Bansberg. I believe Theodora Scarato was signed up to speak, but she could not attend and asked that I speak in her place. Is that acceptable?
Yes, please do.
Oh, thank you. Thank you for allowing me the opportunity. So I'm speaking in reference to the OHA's report on wireless radiation exposure that David Morrison spoke about earlier. So this committee's public statement admitted that OHA can't be 100% certain that wireless radiation in Oregon public schools is safe for children. And the OHA admitted their report was inadequate as they didn't have proper funding. And as David Morrison mentioned, there were some other issues that they admitted that they didn't do properly. And as you all know, this particular situation, if any, is the type that calls for precautionary action to be taken. So we have a suggestion. At the very least, we urge you to make public the list of suggestions that the American Academy of Pediatrics recommends for protecting children from the scientifically documented harms from wireless microwave radiation exposure. So please direct OHA to post these simple suggestions on their website. Parents and staff have the right to know that OHA is recognizing that this exposure can possibly cause harm. There are steps families and staff can take to reduce exposure. Please direct them to simply put those on their website. And OHA's current plan to do nothing is not acceptable. So thank you again for everything you all are doing.
Thank you for your public comment. All right, well, we will conclude the public comment section. I would like to thank everyone on the Oregon Health Policy Board for engaging discussion today, and OHA for presentations and the progress on all the issues we discussed today. So thank you very much. With that, we will conclude the December meeting of the Oregon Health Policy Board. Take good care, and we will see you in January.
Thank you.